Yep, so sorry about that. So climate change is not just an environmental threat, it's a growing health crisis. And with the rise of temperature, they're also expecting a spread of infectious disease like dengue, malaria, and putting millions more at risk. Heat waves and extreme weather also disrupting like food system, leading to widespread hunger and malnutrition in multiple areas. Vulnerable population also facing increasing exposure to life-threatening heat, floods, and air pollution. Hence, climate change is exacerbating health inequalities and creating global health emergency. So the objective for today's presentation is for me to present basically what other HIPS group all around the world is working on climate health. We also introduce DHIS2 climate app, just like a brief introduction of what the app can do and what it looks like. And lastly is how we can best collaborate within our Asian Pacific region on climate and health. So we will talk a bit about like how can we discuss and collaborate. Yeah, so this is the work that we have done so far in terms of climate health from other HIPS group. So this is one of the examples of what we call a climate-informed early warning system. So one is we have infectious disease, namely vector and waterborne disease. So this is an example from Mozambique, from the malaria early warning system. So what they do is that they use weekly aggregate data they already have in DHIS2. They also mix it up with climate data. It can be local or global sources. So for Mozambique case, they get Copernicus data set, and they put it through Google Earth API into DHIS2. Then they will use predictive modeling in external application, and then they will put the result back into DHIS2 to visualize on the dashboard. As you can see in Mozambique, they have created a map to visualize which area is highly affected by malaria. Other one is on nutrition and food security. So this is an example from Malawi. So Malawi, they have DHIS2-based National Agriculture Information System. So what they have is that they work with the Met department in their country. So the Met department in their country, they have their own weather station and satellite data, right? However, they lack local weather data. So what they do in Malawi is that the local staff, they have their tablet using customized app to collect local weather data. And then this local weather data is also sent to the Met department so they can triangulate the local data, the satellite data and data from weather station for the Met department to do analysis and to warn people if there is a flood or drought to secure food, nutrition and food security. We also have an example from Rwanda in terms of climate and malaria early warning system. I apologize that our graph may be too little for those who are here, but what they are doing is that they are triangulate precipitation, temperature and humidity to improve data analysis. So you can see on the top, I'll just read it out for you. So the top is they are comparing humidity data and malaria case, and at the bottom is precipitation data and malaria case. Okay, since I'm from Laos, so I will present it a bit and emphasizing a bit about the activities that we have done as at Q3 this year. So in Laos, as Dr. Visit has already presented yesterday, we have developed a National Adaptation Plan and also Health National Adaptation Plan, which we call in short HNAP. So HNAP is what the government has been created to address health-related issue caused by climate change. And one of the crucial components of HNAP is to strengthen health information system to better monitor and respond to these climate-sensitive issues. So we start off by our pilot project. This one we work with WHO Laos. So WHO purchased 5-year data of climate. We have rainfall and temperature, and we imported it into DHIS2 to compare with dengue cases. So in Laos, we have incident-based surveillance, and we are able to get number of dengue cases daily. So as you can see, the blue area graph is a number of dengue cases, and the red is the amount of rainfall. So we found that there are correlation between climate factors and reported dengue cases, namely if there's more rainfall, more dengue cases. So from this pilot project and the development of HNAP, which launched on mid-2013, I believe, it promised to further strengthen our health information system to maximize the use of climate and health data. So from what we do, we decided to draft some concept notes. So we want to try to do some work among these areas and to see if we can produce any significant result to deal with climate-related health issues. So our first project that we try to do is as same as what we did or already doing in Africa, but we are more focusing on dengue. So the first project is on dengue outbreak prediction. So instead of importing climate data, we are trying to find a way to automate climate data input from Met Department into DHIS2. So the Met Department, they have inflow of climate data from their weather station, from satellite data. We are looking for just the daily data for now. And then after we have those data in DHIS2, we will use the model called EWAS-R model to forecast dengue cases. So right now we are using external applications. So we extracted data, health data and climate data from DHIS2, and then we forecast. But I've talked with a team from Oslo that trying to put this model into the climate app, which I will present it soon. And then, same as in Mozambique, we will create a DHIS2 dashboard to give out any outbreak indicators, so a health worker can use the data to tackle sensitive climate-related issue. So the graph that we have right now, as you can see, the orange line is the number of cases, so these are actual cases, and then we have the blue line, so this is the forecast of dengue cases. We also have some forecast intervals area, so we predicted that the number of dengue cases would fall in the line or maybe in that area. We also want to develop a map on our dashboard as well to better visualize like which area will be highly affected or which area will have a significant dengue outbreak. Another project that we are working on is called Flash Flood Early Warning. So I've talked with a lot of the participants who are joining us today, and this year many countries, including Laos, are suffering from flash floods in multiple areas, which had significant damage on like properties, as well as properties related or infrastructures related to health. So what we want to do is we want to integrate local flood forecast data from the Met Department, trying to put into DHIS2. So this is the map that we, this is a mock-up map that we created. So we have, you can see the plus side, so that is the health facilities data that we have on DHIS2. And you will see like the blue diamond, this one is also in DHIS2, is the warehouse for like vaccines and medical equipment. And you can see the blue area, so this is the flood data, like flood risk area for 5 years. So you can see some of the plus size may be affected by the flood. So this will help the Ministry of Health to better plan for stocking the health facilities or any evacuation plan so that we can avoid significant damages. And other initiative that we plan to do is research on addressing health issues caused by heat wave and heat stress. So this research will be led by Met Department in Laos. So currently we don't have anything to show yet because it's still on research phase, but it's something that we want to do. Okay, so I will present a bit about the DHIS2 climate app. So this app allows you to explore and import temperature and precipitation data into your DHIS2 instance. So the data source for the DHIS2 climate app is called ERA 5 LAN, which is considered the most accurate and complete global climate data set available. You can use this app to explore the weather data directly on the app, or you can also import the weather data into DHIS2, and then you can use tools like Data Visualizer to compare climate data and health data for your needs. So I will show you some example of the visualization we have on the app. So this is the first figure which shows the change in daily temperature in last year in Laos. And the second figure will show how monthly temperature has been changed over 40 years. And this is one of my favorite. So this is a 10-day forecast of any point of location of the health facility. So you can select the health facilities that you want to see, and it will show you a 10-day weather forecast. Another initiative of DHIS2 for climate health products is that we develop a data modeling tools which combines climate and health data for prediction. We call it CHAP in short. So what you can see is that we try to connect many systems. This can be climate data system, external disease surveillance system, and any external software. So they can bring these data together and going through a complex predictive modeling, and then we can send the data back to DHIS2 to support informed interventions on health. And this is the progress update of Climate Works. This is from Q2 this year, so there may be some changes. So we separated by the stakeholder engagement, also which countries have already engaged any stakeholder they have in their countries. So you can see some countries already held climate health workshops in their country. Some are still on exploration stage with their stakeholders. And for climate app, in some countries it is already operational, some is still in the dev instance, and some countries they are just demoed. So for more information on DHIS2 for Climate Health Project or for the Climate app, you can access on the link as shown on the presentation. There are also webinar as well if you want to look at the video presented by our colleagues from other HIPS group. And for the last section of my presentation, I would like to present a bit about how can we collaborate within Asia Pacific region. So for HIPS group, you can contact me directly on how we can work together. I will be the main point of contact for Asia region. If you want to contact with on other regions, like for example in Africa, we have quite a regular regional meetings where each region will share what's going on and updates on what's happening in their region. So if you want to collaborate, so please feel free to reach out to me. And for our development partners or for other ministries in other countries, for country original level of engagement, you can reach out to HIPS representative that you know, or if you're not sure whether they are working on climate or not, you can also reach out to me, and then I will reach out to them to see if they can help you with the climate and health project. And for global engagement, you can also always email at climate@dhis2.org. So this will be like our global channel of contact for climate and health project. So yes, that's the end of my presentation. So I would like to now I would like to invite some of our colleagues to present on the climate and health work. So I would like to invite Dr. Meg from Nepal to come up on the stage to present his initiative on climate and health work in Nepal. Please.
I think no need. Good morning. And namaskar. It's my pleasure to be here, and thank you so much for the organizer for invitations. And my previous colleague has already set us, stage for a discussion on climate and health, so I didn't have to go in detail. But I'll just share a climate change and a health project in Nepal. I'm taking a case study of dengue. And in my presentation, I will focus on climate change and health in Nepal, climate change and dengue in Nepal, and some progress sharing and way forward. Like my previous colleagues told, climate change is not anymore an environmental issue. It is a public health crisis, and it has been recognized globally. For example, recently Nepal has a flash floods. It was very unexpected, and like now millions of people are affected directly and indirectly. And of course health is also affected. Means climate change will include the climate induced disaster as well as climate change affect the distribution of disease vector, also affect to the mental health, also to the non-communicable disease, also induce migration. That means there are huge impacts. So we need a system thinking approach to address all these problems in a holistic manner. But now I'll just take some example from dengue only. So in early 2007, we organized the first national workshop on climate and health, and which defined the major climate sensitive disease and risks in the context of Nepal, like vector-borne disease, diarrheal disease, including cholera, malnutrition, NCD, mental health, extreme weather-related effects, injuries. But I just bolded only first two, because if somebody asks me the question, what are the impact in case of Nepal, we don't have evidence, except for vector-borne disease and diarrheal disease. I mean, this is an area where there are very limited studies, not only in Nepal, whole, I'll say South Asia region. So normally in climate and health, we do the three types of research. First is the empirical database studies, and which may be learning the climate and health relationship using the past data like DHIS2 data, or just having a cross-sectional study in the non-endemic area and detecting the impact and estimating the current burden. And finally, our aim is to protect the population health in futures as well as present. Means we have to design the adaptation strategy. For that, predictive estimation and modeling is very helpful. That means based on our current data and past data, we can project, we can do the forecasting, we can prepare for the future, like early warning system for heat wave, early warning system for dengue, etc. So these are some of the key findings from our previous studies on climate change and dengue in Nepal. We had several entomological studies along a altitudinal gradient, starting from the lowland to like 2,500 meter, and we have reported the disease vector have already shifted at least 2,440 meter above sea levels. And there is a significant relationship between climatic variables and abundance of disease vectors. Similarly, in an area where we reported a high density of mosquito, there is also the high incidence of the dengue cases. And we did also some social science study, qualitative studies, which also confirm the presence of disease vector in the recent year, which coincide with the climate change, the warming trend of the last decades. Just to give the picture of the dengue situation in Nepal, we had a first case of the dengue in 2004. It was the imported cases in a Japanese traveler to Nepal from the lowland district in Nepal. And then in 2006, we had a first outbreak of the dengue with the 32 cases from 9 districts bordering with the India. And in 2010, it was another outbreak with one case from Kathmandu, which is located in 1400 meter, with the 97 cases and 5 deaths, first time deaths reported. And all the 4 serotypes exist in Nepal. We confirmed even in 2006 outbreak. In 2013, we had the outbreak with the 686 cases from 25 districts out of 77 districts. And in 2016, there was another outbreak with the 1,527 cases from 30 districts. See, in this way, it is gradually expanding geographically from lowland to highland. In 2019, it was the first major outbreak in the country with the more than 17,000 cases from 68 districts out of 77. And in 2022, another major outbreak after the COVID-19, largest dengue outbreak with the from all 77 districts, 54,000 cases and 88 deaths. In 2023, all 77 districts affected with more than 50,000 cases and 20 deaths. That means clearly you can see the trend, means expansion from geographically, rapid expansion from the lowland to highland, means all the hill and mountain are now endemic to dengue. And second, not anymore seasonal. The time, they are now perennial, means in all season we can see the cases of dengue in Nepal. And I did just plotting of these, monthly cases, and it showed that, it highly correlates with the monsoon pattern in Nepal. Once the monsoon is start, and monsoon in also, dengue ends. Means we can use the, precipitation as a predictor to predict the dengue cases. So September is a peak time, and monsoon also in September, and after the October, November, then all the cases goes down. But still there will be the sporadic cases. And we also did some analysis for the prediction in the future climate scenario in the different time periods. So it's also so increased risks of the dengue and malaria in case of Nepal. And we did some systematic review and meta-analysis which clearly show that the expansion of the dengue and dengue vectors along with other vector-borne disease is correlated with the climate change in the Hindu Kush Himalaya region, which starts from Afghanistan to Myanmar. And these findings are now also reported in the UN IPCC report 2022. And regarding the health sector response to climate change in Nepal, we did a first national workshop. Then climate change is now mainstream in the health sector policy and planning. Similarly, health is mainstream in the climate change policy and planning. We have also national adaptation plan for the 2021 to 2050, and the estimated implementation cost is $47.4 billion US. And there is a specific component, health, drinking water and sanitation sectors, and the estimated cost is $4.75 billion US. And Nepal is one of the first countries in South Asia to develop the SNAP for 2017 to 21. And we have already updated version, and it is a cost reduction plan, and estimated cost is 7.3 million. But despite this policy response and other evidence, we have still so many gaps and challenges. Right? First is the limited time series data available and inconsistent available data. Like we have a HIMS system, data come from DHIS2 portal. We have early warning and reporting systems from EDCD, and there are other sources, and sometimes there is an inconsistency of data. That is one challenge. So we need a common portal. Second, there is a differences in spatial and temporal scale and units of data. Right? And third one is very limited and sporadic research from and most of the research are from personal motivation. We don't have the nationally representative or provincial representative studies. And very limited national level robust evidence, and sharing of data is also a challenge. I think it is a challenge of all countries, not Nepal only, right? And limited budget on climate and health. Still this is a infancy stage. Globally also like less than 0.5% budget could go to the health sector, climate and health adaptation fund. And just last year was the first World Health Day to celebrate in the UNFCCC conference of the party in Dubai. So, but there are the opportunities, right? First, use of the DHIS2 portal for time series dengue cases of district and the health facility level is possible. Similarly, we have a very long, like more than 50, even 100 years history of recording the meteorological data from the Department of Hydrology and Meteorology that we can use. Even in the DHIS2, we can record the daily cases of the dengue as a notifiable disease. And we have already a climate health analytics platform, CHAF, which can be customized to the Nepali calendar, and we can make a very good analysis, and we can predict to protect the population health. So basically in climate and health data, there are two major issues that we need to address to attract the interest of the policymaker. First, that must have a policy relevance, means data must be presented in a way that is accessible and relevant to policymaker and program managers to inform intervention timely. And second, there must be real data needs, means timely data are essential for rapid response, like what happened in the next month, what happened in next 2 weeks. If we can generate such evidence and communicate to the policymaker, I think they will demand. Means there will be the high demand, not only supply from a researcher side. So we take an opportunity of this global climate and health project, and we want to initiate this project in Nepal with objective to develop a robust DHIS2 based application for dengue surveillance and early warning system using the climate data in Nepal. And we first want to pilot this application to assess the feasibility with the aim of scaling up a broader and continuous use, taking the 3 districts from hill, Tarai and mountain, and 1 district, Kathmandu as a valley. So as a progress, we have already done some time series analysis of the Kathmandu, and we share with the University of Oslo team, and it shows the highly correlated. That means we can use this observed data to predict. And then we have already started the stakeholder engagement and mobilization, and we did engagement with the key stakeholder. We recently organized inception workshop in the presence of Professor Johan Bra from University of Oslo, and we are building a partnership with the academic institutions and also research institute, including government, so that it also enhances the country capacity for other diseases. These are some pictures of the inception workshops, and where the people from the Department of Hydrology presented, Ministry of Health presented, myself I presented, and also from University of Oslo. So it was a very nice one, and there is a high level commitment with the presence of Health Secretary and Additional Health Secretary and others. And we have already selected the districts, right? And we have already sent a request to the DHM, and we have a MOU. So like my previous colleague presented about buying the data, but we don't have to buy now in case of Nepal for the government use. So that already exists. And these are some study sites based on the last 5-year trend. We have taken from the lowland, Chittagong and Tanau, from hill and mountain, and also Kathmandu. And we have already used the global data set, from this DHIS2, and just analyze means there is a clear, pattern of the changing climate, with the April being the most warmest month. Due to time, I will not explain everything, but we see that there is also a very strong heat stress already in the lowland Tarai and the hill regions. So there is a clear trend of the heat stress in Nepal. And there is also, observed, warming trend in many months, right, using the global data set, but still we need to validate with the local data. And this is the precipitation one. So as a progress and way forward, what can we do means we have already upgraded the district health information system to the version 40 in Nepal to enhance the data management and integration capabilities. And we can implement the CHAP customized according to the Nepali calendar. That is also done, ensuring it aligns with the local spatial and temporal context. And now we are also developing a proposal within that project to document the facilitator barriers, so that we can scale up in case of other diseases like the diarrheal disease or the malnutrition and other things. So we take this as a pilot study, and we want to generate the evidence, and based on that evidence, we want to scale up for the other disease and outcome in case of Nepal. Thank you so much for your time and patience. And if any question and queries, I'll be more than happy to answer. Thank you.
Yes, thank you, Professor Meg. So we are a little bit short on time, so we would like to invite our colleague from Sri Lanka to present it on their climate and health work. Please.
Right. Good morning, everyone. I'm Pramil Liyanage, representing Ministry of Health, Sri Lanka. So I'll take you through what Sri Lanka has been doing on analysis of climate health data with the health data. Most of these interventions we have started very recently, and we are still on the initial phase of this intervention. So I won't be able to give you any outcomes, but I will describe the processes and the initiatives we have taken. So the request was initiated from the Ministry of Health, and they identified the requirement of this analysis of climate health data. And then since we are using DHIS2 for a lot of programs in the Ministry of Health, we have identified DHIS2 as the tool for this analysis also, because of the new climate health app. And then we, Ministry of Health, requested support from DHIS2 as the expertise in DHIS2. and a formal request was sent from Health Information Unit of Ministry of Health to HISP, and then collaboration with HISP Center in University of Oslo was also initiated following that. And collaboration with Department of Meteorology of Sri Lanka was also initiated to obtain climate data, local climate data, and we have initiated a lot of pilot cases which I will go through. So the local climate data from the Department of Meteorology, we have basically minimum and maximum temperatures, humidity, wind speed, and rainfall data, which is collected from 23 stations, which has complete data set of in 23 stations, but data is collected over 400 locations, like the daily rainfall and those things. Then first case we started was on child nutrition. I think my previous speakers also mentioned about how nutrition is affected with the geographical data. So child nutrition data was obtained from the Family Health Bureau data set and also the nutrition program. And climate data was taken from ERA 5, and then we have started analyzing correlation between these geolocations, climate data, and nutrition data. So this has been already, it's ongoing, and we have done already the analysis, but there are a few challenges, because if you take like food, which is vegetable, fish like food, they come from outside the location of the patient or the child. So direct correlation is hard to express, but there are some correlations which we are thinking that will come out as results. So another barrier is this data of children are restricted to an MOH level, that is Medical Officer of Health area. So we don't have the exact locations of these children, but it's the MOH area location we have in our systems. So that is also a challenge which when mapping. So this is one outcome graph, one graph we have already made using the climate data and the child nutrition data. As you can see, underweight children, severely underweight children among different age groups, and also the precipitation and temperature being mapped with this data in one particular regional directorate of health services. Right. The second use case is related to mosquito-borne diseases. I think the previous speaker also mentioned about this. So we have one big issue is the dengue in Sri Lanka, and also we have eliminated malaria, but we are continuing surveillance. So these two cases we have chosen as mosquito-borne diseases for analysis using climate data. So this is still at the planning level, and we have obtained the entomological and surveillance data from the epidemiology unit, and then the campaigns, the anti-malaria campaign and the dengue control campaign, and climate data from ERA 5. So what we plan is, we already know that rainfall, these things are associated and it's seasonal, so we already know the correlation, but we are trying to develop further models to detect any epidemics coming up and the magnitude of these things, and which areas they would be affected mostly. So those kinds of analysis we are planning to do using this data. And then another one we have already started is about clinical data. So we are taking data from the hospital information systems. So we are using three sources for this. One is from the morbidity and mortality data coming from the electronic morbidity and mortality system. And then the other one is the hospital health information management system, the HHIMS, where we have OPD data, OPD encounter data. And the third one is the cloud HIMS, which is implemented at primary health care level, and they have registered patients over 2 million and over 150,000 clinic enrollment. So these are at primary health care level, and the climate data is from the local authorities and also ERA 5. So challenges in this hospital data analysis, the data is again limited to the hospital. We don't have the patient location, it's the hospital location we have. So sometimes the hospital catchment area is not very well defined, because if it's a larger hospital, people from outside districts even can come to those hospitals for advanced care. So it's a challenge to correlate the hospital location with the geographical data of the patients. And then, but this is better at primary care institutions, because usually the primary care institution catchment area is defined, and we get better results through this analysis. So that is another good point here. And also we have an issue with the data quality of these systems, because, for example, the OPD encounter, this system captured it as a text field. So it's very difficult to clean this data, because standardization, standardized coding is not used at the moment, which we are planning to implement soon. So you can see about 30% of the data have quality issues in this system. So those kinds of barriers we are trying to overcome. And finally, we are planning to develop a framework. So this is kind of research work which has been initiated. So the collaboration with the University of Oslo by Ministry of Health and University of Colombo has been already initiated. So we are planning for a research, and this outcome of this research will be a framework on using climate health data, especially for policy level decision making. So this has also been initiated and is being ongoing. So these are the interventions we have planned and we have already started. So as I said, I don't have any results at the moment, but probably for the next year conference, we can come up with some good results. So thank you very much for listening.
Yes, thank you, Pramil, for your presentation. So we would like to move on to our next session right now. So apologize, due to a short on time, we couldn't receive any question from the audience. So please write down your questions and reach out to us presenters during the break or lunch. Thank you for understanding. So now I would like to move on to our next session, which is DHIS2 for immunization in Asia. So to start off this session, I would like to invite Sam to present on immunization in Asia region and Laos.
Hello. Yep. Good morning, everyone. So next, I would like to share with you on the immunization implementation in Asia. So I will start with the what we have with the University of Oslo. Then I will go into more details on the Laos case, and then I will have few of my colleagues from few countries to also share their experience. Okay, so I will just show you first what University of Oslo has already prepared, and we'll spend a bit of time on the local adaptation and how, when we have the immunization, how can we link with other services in DHIS2, and that's what the plan in Laos, and I would like a few of the countries also to share. So start with the UIO data toolkit. So this is the toolkit that the University of Oslo, in collaboration with WHO, HQ, UNICEF, CDC, and many organizations that have prepared this toolkit for many programs, and immunization is one of that. And as you can see, for immunization, there are many packages that you can use, starting from aggregate to event to tracker and more. But for today, we will focus on the EIR, but you can also find out more at the link below. So like I mentioned, the toolkit is the collaboration. UIO is working closely with WHO. Based on their guideline, they made the standard package where countries can download and customize for their own country. So with EIR, when they develop this, the main objective is first is to improve the routine data collection. So as you know, the aggregate will take some time when we want to make the monthly report, but with EIR, people just entered all the vaccine, and then the system can produce many reports, and aggregate is one of that. Another one is also data liability. So this is where you can also now see all the, for example, the appointment for the next vaccination, and also many variables. For example, they also have the program rule to check if the certain age, which vaccine that you need to give to the children. And as I mentioned, this package is designed with collaboration from WHO. There are also many countries' experience that contribute to this design of the package. So for the package, you can see, and you can view, they already configured for the birth detail and immunization. So you can also look at the demo for more details. And these are the vaccine that pre-configured for you to see or to test. And this is a good way for you to start experience or doing the demo, or to prepare for your country, so that you don't have to start from scratch. And importantly, it's already available for Android and web, so that when you download and install in your local DHIS2, you will be able to use for your Android and then the web as well. And it also comes with the indicators and standard dashboard that you don't have to configure again. It just works. So you enter data, then you can see how the indicators and dashboard are. So that's the global resource that's available. That, of course, it will be, they will combine many things that when you want to use it, you need to customize and adapt to your local settings. But it's a great point for you to have a look to see what is available, and then you can continue from that. You don't have to start from scratch. Next one, I would like to go deeper for Laos. So this is what we adapt from the global package, and then made customization according to Laos settings. But before we start, this is the lesson we learned before we move on to EIR. These are at least the prerequisites that we need to have, and especially in Laos. So that's what we learned. First, we need to have a standardized facility list and village list. So this is very important and very crucial. Apart from that, then these two has to link. So for example, in Laos case, so we have the list of facilities, then we also do the mapping, like the catchment of each, the village catchment of each facility. So that will help you with more the report when you want to follow up the child and you want to make the population coverage. That is very essential. The third one is also the ID system, because when you use the EIR or you want to track the child, you need to have one ID system that then can talk to other system, but also at the same time, when the child visit facilities, you can also they can use the same ID for for tracking the child and get the child information. And the last one is on the SOP. So when we have that, we started with the Lao, we did the study. I think this is also common in many countries. So for Lao, we started with the aggregate, and the aggregate, also this is the simplified one. So the source for aggregate is from this logbook. So this logbook is by village. So if you can imagine, like this health facility is responsible for, let's say 5 villages, this facility will have at least 5 logbooks, and then another 5 for the outreach activities and other activities. And if you can see, the logbook is designed based on the child. So the child will be recorded in the book and accordingly, but then when you want to do aggregate, it's very difficult, right? Because then you have to come to the vaccination when that happens. And if you can see, the child can have, can get the vaccination at many point in time. And when you do the aggregate, it's very time consuming. And that's where we think that EIR can help, because you don't need to do this manually. Oops. Yeah, so you can replace that with standard report. So when you just provide the service and then you just enter, the health facility, health worker can enter based on the vaccine given, and then at the end of the month, at the end of the quarter, the DHIS2 can provide you this, the monthly report, the quarterly report with all the meaningful things. So that's the thing that we started with, and then we advise, and we have the UNICEF colleague with us who also help in the field that, okay, then if we don't need that one, the system can do for us, so we need to stop using this. So we started to stop using many of these, and we just have one, we call one logbook for this. So this one mainly is to help health worker to enter data into EAR. So it's also reduced the number of the unnecessary columns. So we just focus on, for example, the child ID, the name, if this child is the old one or the new one, and then they have the date of birth, the parent's name, phone number, and then the vaccines. So that they don't have to count or you have to follow. And this is still, for us, even we stop the logbook, but the paper is still important because of the system, as you know, like they can have some downtime. So to help with that, they can still have it in paper, and when they have the internet, when the internet is back, or when they do the outreach, they can come back and do data entry anytime, so they don't have to rely on the system all the time. So now when we move to tracker, these are the important fields that would need to record. So as I mentioned, for the prerequisite, we need to have the ID. So the ID also, we work with WHO and the colleagues to have a standardized ID. And this ID is not only used for EAR, but then it will be used for all the patient or the client. And the rest is also okay. And another part is the address. That's another important component, because that's where you want to know where the child is from and where the child is going to get the vaccine, and etc. So at least these are the minimum field that we need to collect for EIR to work. But in terms of the immunization, is quite simple. And for now, we don't have a lot of vaccine, but we also have some here. So the vaccine entry page is just all the vaccine, but you also can have the program rule to show and hide. But what I would like to mention for this place is we also added the place of vaccination. So this is very important for to report, and also for the health facilities as well, because now they will know the list of children in their catchment. And it's very important for them to follow that child. So even though that child is getting vaccine from other places, if that child is living in their catchment, they have to follow and to check if all the required vaccination is already met. So this is where we also can capture that. So we have fixed outreach mobile, then we can have outside of the country. That is also one of the major important part for Laos, because people can cross to the neighboring countries to get the vaccine. And to be able to capture that, we also need this. And then another one is other facility that I mentioned. Another feature for EAR is for the appointment, the next appointment. So when they finish the vaccination, they will get to choose the next appointment, which is, in the past, they also have done that, but it's not very effective, because when you want to follow a child, you need to do it manually. You need to go through the book, but now we have the system. The system can alert the health center, health workers, as well as the parents when is the next the appointment. And as you can see, because the data entry part is relatively simple, and some facilities well equipped, they can do it real time as well. And as you can see, now they also see everything that they used to see in the logbook, in that book. They can see the child, they can also see the next appointment. So that's on the data entry, but for data use, I think this is the most important and where DHIS2 really shine. So in DHIS2, there are many analytics tools, and you can use it for data to use. But I will just show you on the standard report. That's where the health workers are very comfortable with, and they used to deal with the report, and now they don't have to make it, but DHIS2 can make it for them. And they still have the capability to use that to get all the report that they need from DHIS2. So this is the first one that I show you, the logbook. Now we replace this by the digital logbook, and also very more interactive and also more beautiful than the logbook. So they will have many information here that required for them to follow a child. And if they need to make the aggregate report, of course, you do EIR. If you complete all the vaccination data entry, then at the end of the month, at the end of quarter, or every year, system can compute the report, and then this can be sent to higher level if they need, or if they want to see how their facility perform, they can also use that for themselves. Another important one, and also a shift in the working culture, is this one. So like I mentioned, in the past, it's very rarely allows people for health worker to follow a child, right? Because it's, the main one is very difficult. You have to go to the book, and there are many books. But now with appointment in the IR, you can generate the report. So what I'm showing here is for next month, for this facility, they can run the report, and then the system will check all the appointment for next month. And then we'll list you all the necessary information. You also have the vaccine in case you need to prepare. You want to know how many vaccines you will use, or how many child you are expecting to receive this month. But not over that, you can see the overdue. So if they miss the appointment, you can also check. And not just health worker, but at the central level or the provincial or the district level can also help to check. These are the children that might have missed the appointment. You also have now, with EIR, we have phone number, you have the address. The health worker can either call to check if this child is getting vaccine somewhere else, or maybe the parent forgot to bring the child to the clinic. So this is another report that you can, the health worker can check. And the last one on the report, this is also important for Laos, and also another reason why we need to move from aggregate to individual based. So for aggregate, we can have only facility service, right? We can only know how many doses given at facilities. We don't know if this the child, where the child is from. But with individual base or tracker, we can have both. So if you want to know how facility is doing, you can do that. And if you want to do the catchment, that's very important, because if you don't know the address, you cannot count the children. It's very difficult to do that. But with EIR, it's possible. And this is what I can show here. That's the report. Now, coming back to the first point, now we have the mapping of the facilities and the village, right? So you know that the child in your area is getting the vaccine in your catchment, or is getting vaccine from somewhere else, or maybe from another country. And then you can consolidate and make the report for you here. And then you can compare with the population, and then you can make the more accurate coverage, the indicator. But anyway, even though we started this switch from aggregate to AR for almost a year now, but there are some challenges that we need to work on to address. So of course, EAR, mainly you need to have a stable internet connection. In Laos is quite better now, only in a small certain area that they don't have stable internet, that you still need to rely on the paper and then send to district or to do data entry for them. The next one on the data quality, of course, when we change from one system, there will be some glitches that we need to work on. And the data use is still limited, as I mentioned, because that also about the new workflow that they have to adapt, and the new things that they need to be aware that is possible now with electronic immunization on DHIS2. There's also something about backlog, because they all need to do outreach every day. Mostly they also provide outreach activities, then we need to come back and then fill in the data. There are also the cultural aspects, for example, the names. So usually parents also use their nickname when talking to the health worker. And the last one also, there are some still resistant at the central level, where they are not really sure if this can work, or it will be too much for the health worker. So that we started with doing the phase-wise implementation. We don't stop everything at the same time, and then slowly we try to fully switch to tracker. So that's it for the EAR implementation in Laos. But then I will spend a few minutes on to link with other services in DHIS2, right? Because right now we have the individual data, and I borrowed the slide from DG Visit to come back to this client health registry. So now we have the base database from EIR. We can make that as the client health registry, and this client health registry, or we call it CHR, will be the integration link between many programs, and then other programs can also utilize this. One use case that we are doing now is like, because delivery, we are also changing to individual base. So when delivery happens, you have the child record in the system, it will automatically push to the EIR program that now this child has been born, and then the immunization has at least the ID and the field information that they can start to follow that child if that child is getting all the required vaccine or not. And that can happen for other program as well. And as you can see in the EIR program, we already started, because this is the same child, right? You started with immunization, but you can have the birth detail, you have the growth monitoring, you have the child report. And anyway, because in health facilities is one health worker providing all this service. And I also borrowed this from Dr. Achala, that WHO is also helping to develop this. As you can see, we started with vaccination, but for the child, it's more than that, right? And the same child will have to go through or enroll in many programs, and that's the possibility. When you have the one ID, you have the child, and when you want to record in vaccination, you can do that, and then in the well child also can be enrolled in that. And to follow the child, instead of just one program, you can do the child health development registry. And that's what we are doing. So we move from program centric. So instead of each program collecting their own information and having ID, we have one common ID to be shared with all the program, and all the health program are using the same ID to track the same child in this case, for example. Yeah, so it's just that for me on the immunization and a bit of our work in Laos. So because not only in this region, there are also many countries that are switching to EIR. So then I would like to invite maybe start with Maldives, because Maldives also have been doing EIR for some time to share their experience with us. You want to?
Good morning, everyone. I'm Difana from Maldives. I'll be sharing the experience our experience on implementing a digital immunization program, immunization registry in Maldives. Firstly, we wanted to digitalize our EIR records is to monitor proactively by central level also, because our islands are geographically dispersed. And to enhance data accuracy, moving from the old logbook to the digital system, we believe the human errors will be minimized. And we wanted to track the vaccination status in a timely manner. And for this, first phase of the work was initiated in 2022, January, and finally we were able to launch this system on October 2022. Of course, this is by the hard work of our core team members as well from the immunization program side also. And now we have trained all the facilities of Maldives, and the data entry has started from all the facilities, and we are continuing to monitor all the facility for their accuracy, and we are giving the training as well. And we have initiated a monthly meeting with the island facilities as well virtually. This will help to increase their quality of data as well. And yeah, the challenges we are facing, we have figured that there are duplication of child health records. So now we are auditing the data we have already entered. We have actually entered, captured data starting from 2022, and the auditing work is currently going on. So this will be resolved. And also this immunization program is expanding by including the growth monitoring and child developmental part into this system. And this is, by capturing the child developmental part, we are intersectorally collaborating with our social ministry to by enabling a red flag mechanism to capture the delayed developmental milestone of the children. And we will be launching a public portal very soon for the public to view their vaccination information, and they will be able to generate a digital vaccination card of the children. And we are closely working with our consultant from his Sri Lanka team to start this soon. And I would like to add that because of the successful implementation of our EIR system in Modi's Health, other program also to start their systems as well. And we got motivated to work on other system as well, because we have already worked before also in digitalizing our systems. And we hope you got our information on our current EIR system. So thank you.
Yeah, thank you so much, Maudi, for sharing the experience. So next, I also would like to ask Bhutan to also share, because the case of Bhutan is a bit different on the immunization. Yeah.
Thank you. Thank you so much, and good morning. Like many countries like many developing countries, in Bhutan also, our focus usually is on the service delivery, ignoring the information system. And at the end, we lose track of what we are doing, and we don't know what we have achieved. So similar case is also with the vaccination system also. You know, navigating the burden of the administrative burden is almost like planting a tree during the storms. So it might tilt a bit, but it will bear the fruit. So similar to that case, Bhutan vaccine system was actually developed during COVID-19. Because there were so many things going on, people were engaged in COVID pandemic activities, and we did not really have a COVID system in place. So we developed something called a health facility system. And then from there, when the COVID vaccinations came up, we also needed some kind of a system. But we heard that there is a COVID system in DHIS2 as well, which was, I think, implemented in Sri Lanka as well. But we could not go with that, as we had so many administrative hurdles or the barriers that we need to pass. The administrative clearance, resource mobilization, and also meeting with the donors. So in that case, then we went about with the Bhutan vaccine system. It was actually a few people came forward, a few experts, technical experts, or the ICT experts from Bhutan came forward and volunteered to develop a new system for Bhutan COVID vaccination. And yeah, I must say that rushed decisions in such desperate times is also gives us so many issues at the same time, giving the better outcomes that we really wish to achieve. So Bhutan vaccine system, as I said, it was actually to navigate and then enter the COVID-19 vaccinations. So it had the financial flexibility, the approvals were relatively easy. It was also developed in line with the GovTech agencies, data security policies. So it was actually easy to implement it in Bhutan. And also, since the system was developed by a Bhutanese team itself, so they were, all the health team was engaged in COVID pandemic. So the technical teams, they themselves went to the districts and also trained the health workers on how to use it. So the training component was also not a burden on the Ministry of Health, rather it was taken by some other agencies. So during the COVID-19, it was almost a whole of a society approach where everybody came forward to work with the ministry instead of letting the Ministry of Health work on its own. It was also developed in line with the CRVS system, so we did not have to enter the data, personal data manually, which made data accurate, as well as there were very less chance of mistakes, making mistakes in the data entry. But as it started from scratch, there are so many bugs in it. That was a nightmare when people in the field were entering data. Sometimes they couldn't even open the system because of the huge number of people using that particular system at the same time. The carrying load was relatively less. So all this fixation took us really a huge resource as well as a huge amount of time. Then another thing was with the customization. So Ministry of Health actually wanted something else. The developers did something else. So there were so many miscommunications, and we could not really have an established system. Unlike DHIS2, which is now a very stable and established system, Bhutan vaccine system was relatively new in the field. It has so many issues. Customization itself was issue, and sometimes people did not know what they were actually doing in the field. So these were the major challenges that we had to look at. Now, having said that, then the Bhutan vaccine system actually doesn't have all the routine vaccinations in it. So we are now focusing only on the HPV vaccination, the flu vaccination, and the COVID vaccination. So only these 3 vaccinations are now used in Bhutan vaccine system. And we also, actually, there is no issue with the using of DHIS2 in Bhutan, because health workers are all trained in use of DHIS2, and people are aware of the advantages of using DHIS2. But now, with the coming up of electronic patient information system, we are actually trying to shift everything into the electronic patient information system, where all the patient information, the longitudinal data, and the medical history of all the patients will be in the electronic patient information system. So we are also like on an ocean surface, where we are sailed here or there with the current of the wind as well as the ocean current. So we are not really sure how the electronic patient information might turn out. But if it turns out good, as we wish, and that is our wish, and we are putting in our heart and soul to make it happen. And if at all, if it doesn't work properly, then we might need to shift to the DHIS2 EPI program. Thank you so much.
Yeah. Thank you so much, Bhutan, for sharing the experience. And last one we have from his Bangladesh, also would like to share the experience in Bangladesh. Yeah.
Good morning and assalamu alaikum. Thank you. The WHO launched the expanded program on immunization in 1974. And on the trend of that, an EPI Bangladesh was launched in 1979, 7th April. And from the beginning, the WHO is supporting the whole immunization program, and WHO mainly manages the data entry and everything. So, that was mainly centralized and mainly based on Excel. The later on, they moved to the access-based system. And on the journey of HMI system in Bangladesh, we started in DHIS2 implementation in 2010. So in 2012, EPI officially requested to build based on the DHIS2 based EPI reporting. So as a part of German development cooperation, me and my team took the initiative to convert the EPI reporting, the routine EPI reporting in the DHIS2. Later in 1917, UNICEF and HIS Bangladesh supported development of vaccination logistics, cold chain, and other tracker-based implementation. In the development of HMIS in Bangladesh, we are very grateful to several people. One of them is Professor Dr. Azad, who is the Director General of Health, Minister of Health that time. And we are also, another leader was Mr. Shukrad Rahim Janov, who is the head of health of UNICEF that time in Bangladesh. And I'm very glad that he is here in this room, and I like to apply for him. So, the next thing I want to present is the MR campaign in 2020. This is one of the largest real-time monitoring of immunization campaign we had. So that was actually, for the target was the 34.6 million children to achieve 95% within 7 weeks in 2020. So that was the target. And we took the challenge to build that system on DHIS2. So in DHIS2, we built that, and we have to follow, we baked Android tools for the offline data collection and others. So you see the development of public dashboard so that the people can monitor real time. Every day they can know how the vaccination is going on so that there will be no gap and we can achieve the target of 95% was the target. We achieved 107%. More than 36.6 million people, children we vaccinated. So this is actually way beyond our imagination even. So we don't think that we can even achieve the 90% of that targeted 35 million children. But we achieved 36.6 million children vaccinated in 7 weeks. And everything within the DHIS2. So this is a bit of challenge for us and a scaling test for the DHIS2 as well. So the challenges was we have more than 500,000 org units. Be careful. 500,000 org units. Vaccination center, vaccination site, all is 500,000 more than. The user was 15,000. The 15,000 user reporting to the DHIS2 system. And we have to control, manage, and everything within the DHIS2. And we are also very grateful to the DHIS2 core team because they supported us a lot that time. And performance of scaling is a really challenge, and we somehow manage that. And we built a public dashboard so that the data can be visualized every day so that the supervisors know where the gap is, if there is any logistics issue, and we have to address that. The second part I want to show you, the aggregated data collection. So there is several data collection, especially the vaccine logistics is there. So the vaccine logistics, we have the vaccine stock, supply, and indent system built in the DHIS2. So that's actually worked very well for the vaccine logistics system inside our 636 reporting facilities, where the vaccine logistics are reported and also any indent. So the indents and stocks are usually headquarter is weekly, and other places is quarterly and monthly. So this is some example of aggregate data collection, public portal and DHIS2 portal. So left side is the DHIS2, this one is the public portal. The EPI management and macro planning. So the EPI macro planning, we have the sub-block level, where is 170 facilities, 110,000 facilities for the micro planning site. And yearly there is a urban, for urban we have 5,000 facilities. And this data is collected in yearly, so have the yearly macro plan using as a denominator for the EPI reporting systems. So this is macro planning, aggregate macro planning, the dashboard. This is a public portal. So the immunization tracker. So immunization tracker, we have several immunization tracker. This is the routine immunization tracker, which is the e-tracker. Currently is it implementing in 4,575 facilities. And total user currently is 15,439 users. This is actually Android-based app, but DHIS2 Android app. So there we are using, initially we started version 34. Now we move to the version, you see this version 41. But later on, we actually moved to several other trackers. For example, we have the HPV tracker and the COVID. So the front end we changed from the DHIS2 Android to our custom thing so that they can, those are one-time vaccination, they just scan the card, automatically the vaccine is registered and reporting is done. So thank you, everyone.
Yeah, thank you so much, Hanan, for sharing the experience in Bangladesh. So, and once again, thank you for all the presenters for sharing the experience. As you can see that for immunization, even though we start with immunization or we focus on immunization, but as I hope that you get the concept of doing this can be applied to many health programs as well. So now I think that's conclude for our immunization, and I would like to hand over to Anu for the next agenda.
Yes, so hi. Before we going for a tea break, we would like to arrange a 5 minutes Q&A session. So if you have any questions for immunization or even for climate work, yeah, you can ask our presenters now. We have 5 minutes. Any questions? Yes.
Thank you so much. Very nice presentation, especially to Lao system, the EIR in Lao. So I think there are a lot of, how to say, interaction between different systems in Lao, and starting from the deliveries to EIR to other. So, bring how this system can be connected together. Is it basically, I have two questions.
Hello, now like this one is working.
Okay. Hello? Closer. Hello? Hello? Better now? Yeah, I think I have two questions actually. One is how you can identify the child. I know you have a patient-centric ID, but one patient move from one system or one place to another place. How you can identify them, or I mean, how will they bring this ID with them, or what happens if they lost it? Second question, the interaction between and the data exchange between different systems. Do you have a policy or a regulation for data security or privacy in place to share information, or is like any agreement between different programs? Thank you.
Yes, thank you. I can address those two questions. So for the first one, how can we identify? You also mentioned that we are using client health ID, right? So each child or each client will have the ID. So the ID is also will be given to the client as well as part of the card. So he or she can travel with that card. But in case that card is lost, even though we can search for in the system. So you can search by date of birth with last name, date of birth with your address, etc. So that's where, and then every facility is using DHIS2, so you can do the search for the whole country. Now they will link to your second question because it's also linked to data security and privacy, right? Because people can search. And I would like to give two things. First, on the rule or the law or legislation. So that one allows we have the law on data, individual data, but that's from Ministry of Technology. They also have some certain guideline how you should protect that data. But for health, I think it's a little bit special because that data for private and other companies need to be strict. But for health, it can be flexible. But we are working on making and adjusting that part to accommodate the health settings. The second one on the system itself, we also limit. So two things I can mention. First is we limit the search. Even though you can search for any, but you need to have more variables to search. You cannot just use the name or just phone and then you can search for anyone. So that's the first one. We do the combination of search. At least you need to know more about your client before you can do the search. Another part, we also utilize the log. So we set in the back end. For example, one health worker, you can search up to 100 records in a day for Lao example, because we don't have that much population and you don't need to search more than that. If you do something more than that, then the system can flag, oh, somebody is using, searching so much, we can at least stop that, not allow the search and wait for the review. So these are the few things we are doing, and I hope can answer your questions. Yeah.
Okay, thank you, Sam. So I think we have time for one more question. So anyone have any question?
Thank you. My name is Mana. I would like to ask a question regarding the linkage to other system in terms of the health patient. I don't know whether you have already thought of linking the LMIS, the Logistics Management Information System, into this linkage.
At the moment, we have not, but that's another plan. We would like to utilize that logistic to compare the utilization of the vaccine versus the patient. And at the moment, it's not in place. We just started with EIR, but obviously in the near future, we will need to link with that. Yeah.
Thank you.
Thank you.
Just to follow up on that question, like we have a LMI session tomorrow morning where Breno is sitting in the front. So if you have anything, you can always catch him. He's our LMIS person. He will have a presentation on that. But yes, Anu?
Yes, so thank you, John. We would like to invite all of our participants for a tea break now. So our next session will start at 11:10. So please enjoy your tea break and come back to the conference room before 11:10. Thank you.
Anh Mai cho cái này đi anh Mai. Sạc.
Ủa sáng giờ không muốn sạc rồi.
Sạc đi sạc đi sạc.
Ủa nhưng mà hôm qua đem về mà sao sáng này nằm ở đó?
Hôm qua quên mạng cái mạng gì nữa. Em hỏi. Sáng vô nó nằm sẵn ở đây nghĩa là hôm qua quên mang về cái gì nữa. Hay là gắn vô cái cốc cho nó khủng không anh?
Ok. Ủa?
Bà mốt đó, em hỏi bà mốt nhưng bà mốt báo á.
Bà mới đi một tin để báo thôi. Whose laptop is up there? I know.
Hello all. Yeah, I hope you have a good tea break. So for now, I would like to move on to our next item on the agenda. So same as yesterday, for this session, we will have our participants, some of our participants, to come up and present about their local DHIS2 implementation stories. So I would like to hand it over to Michael to facilitate this session. Michael?
Thanks, everyone. For those of you that don't know me, my name's Michael Buttsworth. I do a couple of days a week for the University of Oslo, and I predominantly, well, I help out in the Pacific with the coordination of DHIS2 implementations. Today, or this morning, we're going to have 4 presentations. The first one from Papua New Guinea, second from the Maldives, third from Cambodia, and then we'll get UNFPA Afghanistan to present as well. And yeah, I know we haven't had a lot of time for questions and discussion, so we'll try and move through fairly quickly. I do encourage, if we do get time, to ask plenty of questions, because I think this is a real learning opportunity, seeing what other countries are doing. But if not, make sure you meet up in the coffee breaks, the tea breaks, and ask plenty of questions there, because I think that's the real value in these sorts of conferences. So as I said, I work in the Pacific, and this year unfortunately we didn't get a lot of the Pacific Island countries here. Last year I think we had Vanuatu and Solomons who have full-blown HMISs using DHIS2. But this year we've got a new user, a new country, PNG, Papua New Guinea, and they were able to attend. They've very much started their journey with DHIS2. They have a very good system in place at the moment, but they're using or looking to explore DHIS2 initially on the periphery for certain implementations. So I'll welcome Mr. Pius up to give Papua New Guinea's presentation. Thank you.
Thank you, Michael. Everyone in the room, good day to you all. Thank you for the organizers for giving us this opportunity to present. And thank you, Michael, for making it possible for us to travel all the way from PNG to here. I have a very short presentation. As Michael has said, we are new to introducing DHIS2 into PNG. So I'll be presenting on DHIS2 pilot for reporting and data sharing in PNG. I have Mana with me that we travel from Port Moresby. Okay, whatever activities, initiatives that we do in digital space, we follow the National Health Plan. The current National Health Plan 2021-2030, in it, we have 200 indicators that we must achieve from the national to all the way down to the facility level. Sorry, I just want them text messages to appear. What I'm gonna say is written on the bottom. Sorry about that. We have a M&E framework that is aligned to the national health plan. So our M&E framework has 136 indicators. That's for annual reporting, and 64 indicators are measured for periodic reporting. So in existence, we have the eight digital systems that's collecting data. The main system that we have is the electronic National Health Information System that is collecting service level data. So that's the reporting pathway. The diagram is not very clear. From facilities, they report up to the provincial health authority, provincial level, and then to the National Department of Health. So it is a primary system to collect health service data, as I've said. Discharge hospital information system data is also collected. And we also report medical supply system data, HIV, TB data as well into the ENHIS. So we have introduced DHIS2 into the provinces. We have 22 provinces, but we are piloting DHIS2 in one of the province, and it has shown to be a successful pilot. And this is it strengthens the linkage between resource allocation and accountability, use existing information, resolve the lack of transparency and availability of strategic information. And this is burden on timely reporting. So that's the intervention using DHIS2 for the 22 provinces that we need to scale up. So this is the dashboard. These are some of the data visualization that's happening with the dashboard that's been implemented. We have different systems. Data has been collected and then integrated into DHIS2 and analyzed in the using intelligence tools. So that's the data architecture that we have with technical assistance from Impact Health Project. So from the dashboard, we have shown that it has shown that there is success, and the department is willing to scale that up to other provinces as well. So we are getting assistance from HISV Vietnam to do this project. So our next steps is to complete proof of concept and dashboard toolkit next week, like from October, and the minimum viable product for PHAs. So we want to expand to other provinces as well. It looks at data integration, finance data, supply data, HR data, ENHIS data, and supervision checklist data. So all this data has been integrated. Instance hosting will be decided, and training should proceed with the expansion as well. I think that's just about implementing DHIS2 in PNG. We are, as I've said, we are new to DHIS2, but we are seeing the benefits from your presentations. We are already seeing benefits what DHIS2 can do for us. So we have piloted it, and then in one province we have seen the result of it. So I think the next steps is to scale up DHIS2 in the country. Thank you.
Thanks, Pius. Maybe just stay up there for a minute. You can't get out of the limelight that quickly. Just if there are any questions for Pius, please ask away. So just while people are having a think, I think PNG has quite a good system in place, but it works very well because PNG is very, very remote. Very remote. Some areas are very, very hard to get to. And the system, the ENHIS, works quite well, but that's because there's been a lot of investment there through ADB. I think when they initially set the system up, they flew helicopters out to facilities to do trainings and things like that. And it's working well, but I think for some things it's not perhaps as flexible as they needed it to be. So they're exploring DHIS2 for some aspects, so for COVID-19 surveillance as well, and they've looked at HIV But yes, this PHA dashboard's really about integrating and presenting something that at the provincial level, so the administrators can view data from multiple systems. So it's very much an integration type project. So.
Yeah, I'll just add on to that. DHIS2, some of the non-government organizations are using it. One of them is FHI 360. So what we are trying to do is in the FHI 360 DHIS2, it's got the COVID-19 data. So what we're trying to do is integrate that with the dashboard. And also we are looking at the program level data. The ENHIS reports the service level data. So for each program, we want to use DHIS2.
Thanks. And one quick thing, unless there's any questions, was just, yes, World Bank is very much supporting that project, and we very much thank World Bank for helping support Papua New Guinea to attend this conference. So thank you, World Bank.
Yes.
Any questions? No? Okay, we'll move on. If you think of anything, feel free to ask. Okay, the next, did you want me to talk now? Anu, introduce the next country? Yes, so the next country I believe is the Maldives. Yes, so Maldives, and certainly while they're coming up, I know there's a lot of similarities with some of the Pacific Island countries too with the Maldives, just that remoteness and small island states. It's very different to what we heard earlier with Pakistan, Bangladesh, etc., where there's very, very big populations. Okay, over to you.
Good morning, everyone. Again, I'm Difana from Maldives, from Ministry of Health. So in this presentation, I am talking on enhancing sustainability of DHIS2-based public health management systems in Maldives. So these are the key points that I will be highlighting in my presentation. First, moving into the modules we have currently implemented and we are currently using. So this includes routine health information module. This is the first ever module we started using in Maldives. This was in July 2019. In this module, we are collecting routine statistical information from public facilities and private hospital as well. And then we developed, we piloted this electronic immunization registry on October 2022. In this registry, all the vaccines from birth to death we are recording. And then we have our primary healthcare registry. We piloted this in one atoll first in March 2023. In this year, we have expanded, and now 2 more atolls are using in this registry. And through primary healthcare registry, we are monitoring disease progress and the disease status. And then we have National Cancer Registry. We started using National Cancer Registry on November 2023. First, we are starting this in 2 facilities of Maldives, 2 biggest facilities in Maldives. From one facility, all the legacy data starting from 2019, they have completed entering, and now we have started to enter data from the other facility as well. And in the National Cancer Registry, we have individual cancer informations. And then we have lymphatic filariasis surveillance module. This was started on February 2024 to screen for mass screening of filaria. Importantly, this module was developed in the Maldives by our team, those who were trained for this, and this module was developed within just 2 weeks for this mass filaria screening. And then these are the modules we have prepared for piloting. So I want to say that these modules were ready, but because of server compromisation, we were unable to start. And these modules includes communicable disease surveillance. In this module, we will be notification and investigations of communicable disease, and then we have maternal health module, antenatal and postnatal care will be capturing. A growth and developmental module, we will be capturing growth and development of children aged up to 5 years, and then tuberculosis screening module for mass screening of TB, since we are working towards zero TB elimination. And these are the future commitments we have. In this, most of the modules we have finished the pilot scoping also, and those includes in tracker-based system, injury surveillance, a mental health module, and thalassemia and donor registry, a port health one, and migrant health for migrant health screenings. And in aggregate ones, we have family planning, and we want to migrate the Excel-based inpatient diagnostic report to a digitalized one. And also we are redesigning some of the modules that we are currently using in the DHIS2. Those includes laboratory and diagnosis reports, surgery reports, human resource status reports. And I will go through some bottlenecks that we have identified for sustainability to make this sustain. So those include the limited capacity of the local workforce. As a result, now we are currently relying so much on the external experts, but we are trying to, and we have already trained so many staff from Ministry of Health in 2023. As a result, these trained staff are actively involving in the development of the modules and other things. Those staffs includes program level staff as well. They have involved actually in compilation of metadata of growth monitoring modules as well. Then we have a need for interoperability. So currently we have so many standalone systems in place in Maldives, but none of the system talks to each other. So we have hired consultant with the support from WHO to assist in the API integration work. So then in this API integration work, first we are targeting to the major facilities in Greater Amala region. Now the mapping tool has been finalized, and facilities will also make changes, required changes for the missing variables. And and before the end of this year, we are targeting to bring one facility from Greater Amala area to bring on full automation. And we have auditing, data quality, maintenance, and user support. Current, even with the limited staff and resources, we have taken steps to ensure data quality and provide ongoing user support. Provide timely user support. We also have to plan to include a ticketing module or utilize DHIS2 messaging features as well. So our target is to enable a systematic auditing and feedback mechanism in near future. So to maintain server capacity, at present our servers are based in another ministry, under another ministry. So we impose challenges in daily monitoring of server capacity, performance, and to maintain the server capacity and performance by our core team, which is based in Ministry of Health. So we are working on getting access to server monitoring tools. So, need for creating a shareable electronic health record. This is one of the missing piece actually, which we need in Maldives now. Because we have around over 180 facilities directly under Ministry of Health, and at present shareable electronic health record is not available. And we believe that most of the clinical information that we capture from the systems are relevant to DHIS2 modules we have, and with the support from WHO, we are working on establishing an EMR development work, and this will link to an electronic health record, and we are planning to initiate this year. This electronic health records will be integrated with the DHIS2 modules that we currently have. So to enhance data use training has been planned from this year onward for the data entry users and policy makers. And one of the main thing we are working on is creating a public portal for, and we are giving public access to view their information. So in first phase, we will provide them growth monitoring charts, EIR records, developmental milestone check-in, and primary healthcare records. So let's have a sneak peek at the public health portal that we have. This is the electronic immunization record, and from this we can also print a digital vaccination card, and we are also once we have started the to capture the travelers' immunization records, they will also be able to have a digital vaccination card for the travelers as well. And this is the growth monitoring chart, and this is from the growth monitoring chart. Actually, they can also view their values as well, and they can, and also this was made, actually this growth monitoring chart and developmental milestone, we have made as how it looks like now on their current book. So that it will be easier for public to understand, and their acceptance will be more. And this is the developmental milestones record. From this record, now the thing we are working is, once if there is a missing milestone of a child, we are working on a red flag mechanism by enabling the notifying tool in the DHIS2 to inform other ministries so that they will be able to find those children who have delays in developmental, so that prompt action will be taken by referring to other doctors' specialized care. And vitamin A and deworming. This is the primary health care record. We will be able to see how many visits the patient visit, monthly visits, if their diagnosis, and their other examinations as well. So these are our technical partners. Thank you for listening.
So thank you so much. I'll stand away. I know I listened to the Maldives presentation last year at the conference and was impressed, but obviously they've done a lot more work now, so that's very impressive. Any questions? I think everyone might be getting hungry for lunch. There's a lot presented there, a lot of new initiatives, which is great, a lot of new plans as well.
Feel free to ask any question around later.
Just one question on the mass campaign.
Yeah.
Just one question about the mass campaign. Like you're using the mass campaign for using the aggregate module, or is it like how we are trying to implement that? Because most of the countries, they want to try to also start with mass campaign using the DHIS2. So my question is, are you using DHIS2 for mass campaigning? And then what is the suggestion for other countries, how they can try to adopt the mass campaigning things which you have implemented in Maldives?
Currently, we had our file area mass campaign, which is a tracker-based module. We track the patient. So it was very easy for us for that. Actually, in the file area campaign, most of the information were collected from the migrants and then Maldivians, local people. And because this disease was notified from their side, and yeah, it is really useful, and we made this module within just 2 weeks by our team. We were able to know the timely updates and like the statistics and everything to take immediate action.
Did you have anything else, Pamod, to add, or?
Again, it's quite contextual because Maldives is a small population, and they have, I mean, the level of infrastructure that they have and the health facility network is also quite unique. So given that they were able to do it at individual level, but in a different country, of course, this may not be so feasible.
Yeah.
Okay, any more questions? It's bright lights here. I have to struggle to look out. Any more questions? Okay, thank you very much.
Thank you.
A round of applause. Great presentation. All right, now we'll have Cambodia, please, a representative from Cambodia to present.
Thank you, Mr. Amsi. Good morning, everyone, again. I think we are still in the morning. So my name is Ieng Van Ra. I'm from the WHO Cambodia. Today I'm representing our delegate from Ministry of Health, talking about our health information management information system in Cambodia. So talking about DHIS2, Cambodia is not news to the system yet, but yet it's not very popular in the country. So we use it since 2013, and then for our indicator-based surveillance system. And currently there are a few programs that are using it. So today I want to present you about the current health information management system that we are using now in the country, but not DHIS2. So I will present about the current HMIS, a little bit about the health structure and the data reporting flow for your understanding. And I will talk also about the assessment that we have conducted last year, and also the needs for the country to transition the current HMIS, and also the next step that we will do to enhance our system. So talking about the current HMIS in Cambodia, it was built locally in 2010 based on the PHP 5 and MySQL also version 5, which is very old version right now. and it has been rolled out to all the public and private health facility in the country, from national to health center level. So currently we use it to collect data, aggregated data, and then the system can generate a simple report. However, they are still limited of data visualization in the system. I think similar to other country, different health programs have their own platform. They also collect data on aggregate format and also a case-based format at the health facility level. For the HMIS, we currently have around 100 indicators, and we plan to add more 68 indicators following our health strategic plan 4 this year. In addition to HMIS, the WHO have supported Ministry of Health to develop what we call National Digital Health Strategy 2024-2033. Actually, we missed one. As part of the ASP4, the idea is to to collect data from different disease programs and to ensure the interoperability, scalability, security, and sustainability for the HMIS. So if we talk about health structure in Cambodia, I think similar to our neighboring country. So we start with Ministry of Health, which is at the national level. And we have one department responsible for HMIS, which is the Department of Planning and Health Information. Below National Ministry of Health, we have Provincial Health Department. So in Cambodia, we have 25 provinces. So we have, again, the same number of the Provincial Health Department. Below the Provincial Health Department, we have Operational District, which we have right now around 103. Below the operational district, we have referral hospital. It's kind of district hospital. We have 96. And below operational district, we have also health center, which is the primary healthcare level. We have around 1,300 health center. And in addition, we have also private and NGO health facilities. Forgot to mention about provincial hospital. We have around 25, which is under the management of the Provincial Health Department. And also national hospital, we have around 12, which is managed by the Ministry of Health themselves. And we have also national program. And in Cambodia, currently we have around 17 million population. In terms of data reporting form, so at the hospital level, referral hospital, provincial hospital, and national hospital, we have one form, we call it HO2 form, for this facility to report every month. So it's a monthly reporting aggregated data system. And at the health center level, we have one more form called HC1 form. And for the private and NGO hospital, we also have another form to be reported. So talking about the HMI assessment between 2022 and 2023, we have identified several challenges related to the current HMIS system. First, it's about the fragmented system. So the current HMIS is working in silo. It doesn't connect to any other national program data system. So that's created a lot of issue in terms of data sharing and also the quality and timeliness of the information. As mentioned earlier, the current system is based on PHP5, which is very old technology comparing the current system, which already in the PHP age or later. So this creates a lot of issue in terms of sustainability and upgrade, or create a lot of challenge when we want to improve the performance of the system. And the system currently doesn't support mobile interface. We can use only on a computer platform. In terms of data analytic, we have limited function for data analysis and visualization. So we can generate several kinds of report, but still it's not enough. So as mentioned also earlier, the different programs create their own system in addition to HMIS. So it creates a lot of the duplication of data entry at the health center level. So it creates a lot of burden for health staff to report the data into different disease program plus the HMIS. Since it's a local bill system, and we have limited resources at the IT resources at the national level, so the cost to maintain the system is quite high, because especially when we want to improve the system, we want to add new indicators or remove indicators, we need to do to change the program, and you need IT developer to reprogram it to make it happen, and this also take more time and effort. Lastly, we found that the data validation is still also limited, because in the system we just allow them to enter, based on what we have requested to submit, but in terms of data checking and validation is not available in the system. Following the assessment, the WHO recommend two options for Ministry of Health to consider. So option one is to switch to a new, brand new system for the HMIS. And second option is to upgrade the existing platform. So if we choose option one, so that we discuss about some pros and cons about these two options. So if we upgrade to the new system, we need to work on the interoperability and data standard, which we need to develop more API and data exchange protocol to get data from other systems without doing duplicated work. And we need to prepare for system replacement, which the one option that we think about is to use DHIS2, so that we can enhance our data visualization and also interoperability. And also user interface, which as we know, we can use both on mobile for DHIS2. If we use the new system, we need to invest more on the capacity building, because the system will have different interface, different kind of usability. So it requires to retrain all the users that are currently using the current system. So that will cost more, and then will take more time. So I think for the option two is to upgrade to the new, to upgrade the existing HMIS. But I'm not go through this option, because it seems like currently the Ministry of Health already chose the option one. So I think you can read through this recommendation. Yeah. So for the HMIS in Cambodia, the new HMIS that we want to have, so we want to focus on the new system that have capacity to interact with other systems, such as electronic health record, and also to support data exchange. So we need a system that can do more data analysis and also reporting, and we want something that can be generated or created by users themselves without requiring programming language, and also it will be used to support decision making at the bigger pictures. In terms of functionality and customization, Yeah, we want to be able to customize the system to support data entry and data retrieval, enable also the usability in the mobile platform. Yeah, and especially it's easy to customize. Like we want to add, we want to change, we want to update, or we want to delete any indicators as we wish. Because as you know, the indicators might change from year to year, depend on the needs of the country. So we can be, at the user level, we want to be able to do it. In terms of data storage and management, we want to have a secure location and also centralized platform that can be maintained and in a secure place. And especially, we need to be able to do it a data backup on a regular basis. And in addition to this, the data security and privacy of the information need to be available in the new system as well, especially related to user authentication, data encryption, and audit trail in the system. So we need a system that can support decision. So we want a system that can generate alerts and also provide some kind of prediction capability for the policymaker or manager, so that they can be timely informed about the evolution of the data, and then can take the right decision. Also, because I think the staff turnover create a lot of issue, we need to retrain them again and again when there's a lot of movement in the health workforce. So in the new system, we want something that have training and support built in the system, so that user can follow or can replicate their knowledge to others easily. And also, lastly, we want to have a system that can can support also the monitoring and evaluation. So a tool that can track the program performance, and especially to measure all the indicators for their efficiency. So in terms of next step, we just come back from Oslo last 2 weeks. We had a fruitful discussion with our colleague over there, and we have a draft of a transition plan, action plan. And then next step is to endorse the plan so that we can start our following step. And right now, we will continue to discuss with our HIS Vietnam on the system configuration. Part of the work plan as well, we will establish the core team and build their capacity on DHIS2. Also, we will have to revise our current indicators because I think the current indicators are not up to date, and there might be some news, and there might be some old indicators that are not used. So I think that's the more important, because even you upgrade to the new system, but the data is not used, then it doesn't make sense to have a new system. So make sure that we have up-to-date indicators that are usable by all the stakeholders. Next is to update the health facility master list. I think the Ministry of Health already working with the WHO, with CHI, with other partners to update this list right now, and we are almost finished. And I think there's no issue in terms of using this data when we move to DHIS2. With that, Som Okun, cảm ơn and thank you.
Thank you so much. Yeah, that was a great presentation, and I think probably familiar to quite a few people, that transition to DHIS2, and the decision-making process around that was very interesting. I think moving towards something that they feel is sustainable moving on into the future. And it's also good to see all those, you know, those thoughts around the building blocks and getting very prepared for bringing in DHIS2 as well. So are there any questions on that? Great, we've got questions.
I'm Javindra Pandey from Nepal Ministry of Health. Thank you for your nice presentation. You said in your presentation that there is a digital health strategy in Cambodia. And in that strategy, there is interoperability system also. You said that. Is the interoperability system is within the health system or any other systems like social welfare system like that? Is there any interoperability between health, that DHIS and other systems of government and non-government?
Yeah, I'm not sure I understand correctly, but let me try to answer. Also, our colleagues there might be able to answer. So we developed this strategy in 2019, and now it still has not been endorsed yet at the moment. And in the strategy, there are several strategic directions. So one is about interoperabilities. And we in the strategy, we said we will establish a CAMHEA, Cambodia Health Enterprise Architecture, which lay out all the different systems in place, starting from the case-based aggregate up to the national level. And in this health enterprise architecture include the non-health sector as well, like COPS, IPPS, identification, I forgot the full word, insurance as well. So there's all the system in place, but since the strategy have not been endorsed, so I mean it's still a room to add more. And as you know, we developed it in 2019, so it's quite like outdated right now. So we need to revise it a little bit.
My question is, what going to do with the old data since you're moving to the DHIS2? What about the old data? What going to do?
I think there was an agreement that we have to migrate all data to the new DHIS2 if we will be planning to do so. And I think HIS Vietnam is willing to help us on this. I know it's going to be a huge challenge to migrate all data, especially in the current HMIS. We have three versions already for the in terms of the back-end system. So version 1 might have different structure. If version 2 may have different structure to version 3. So it will be a challenge, but I think we hope we can try our best to migrate the system. And especially we will migrate during the transition as well, so it might take time. So you cannot stop them from sending data, so it's like we need to have a better plan for that.
Thank you. I know you did the presentation on the assessment. I would like to ask if there is a digital health maturity assessment been conducted across the provinces to see the maturity stage before you migrate to a new system.
The maturity, right?
Yeah, a digital maturity assessment, has it been already conducted together with this assessment?
I think this initiative was supported by Wipro, our regional office in the WHO regional office in Wipro. Actually, government did not do it, but we, as the WHO, we did it, like this maturity assessment before the HMI assessment. But I think the result was not like publish or share in the public, because we lack a lot of documentation, especially, you know, when you do this assessment, it requires some evidence, documentation, and all that we don't have on hand. So we didn't share the result actually.
Okay, great questions. I think, yeah, just for your information as well, there is a DHIS2 maturity assessment as well, and I think there's a presentation on that or some information on that later as well. If there's no more questions, I'll move on. But that was, sorry.
That's a good point, because the maturity assessment that I just mentioned is about the digital health in general, not DHIS2.
Yes,
Yeah.
yes, yeah. Great, well, a round of applause for Cambodia, that was excellent. And then final presentation for this session is UNFPA Afghanistan. So I'll invite them up to the stage. Thank you.
Thank you so much, and good afternoon. I would like to present the UNFPA Afghanistan country implementation of DHIS2. So there is a HMIS, so I am just leaving that part, and how the UNFPA have implemented the DHIS2. And taking this opportunity, I'm also sharing the our future plan, and as all the experts are here, so I will also then learn from them then how we can move forward. So before going forward, we will be, the outline will sharing the mission of UNFPA in Afghanistan. So I know that most of you will already know, and what services UNFPA is providing in Afghanistan, and also how we have implemented DHIS2 within the UNFPA country office, and what is our future plan and also strategy that we are going to. So I think most of you know, so the UNFPA missions are all around the world, but there's a little bit change in Afghanistan. So is to promote the protect of reproductive health and right of individuals, especially adolescent and youth in Afghanistan. But there's one thing changed, because UNFPA agency is a development agency, but in Afghanistan, because of the current context, UNFPA is also providing humanitarian support to the flood affected area, to earthquake which happened 2023, mini flood in 2024. So now I will just go to the national boundary or National Geographic. So so Afghanistan have the geographically 8 region and 34 provinces, 426 districts, and public facility. I've just mentioned about the public, and 4,553 public facility. And what UNFPA is doing is active in all the 8 region, 34 provinces, but in 290 districts, and we have 935 facility, which we call service delivery point. And the important thing is that UNFPA is providing services at the remote area, in the community. So we have a FHH, which is called Family Health Houses. We have mobile health team, which providing services at the white area. We have other services in psychosocial services, or GBV. So we'll come to that. So overall, UNFPA in Afghanistan is providing services in maternal and reproductive health. As I mentioned, humanitarian, because of the current context of Afghanistan, and we are providing services to adolescent and youth. So how we have implemented DHIS2? So I want to be very concise, so I will focus on the last part, so also I can share what we are planning to do. So we have integrated all humanitarian services into DHIS2, maternal reproductive health, GBV, adolescent and youth, and midwifery helpline. And what we wanted to achieve is what is the goal of DHIS2. So this is what we did in Afghanistan. So we want to have a data collection, and this all data is we are collecting aggregated level. So we have a data set for it, and also we have implemented a validation. But beside the available validation, we have also customized our data set for the different type of facility level. So if one facility is providing one services, the other indicator is automatically disabled. And also for data analysis, reporting, and data visualization. And one thing we have done another, so we have a lot of donor, as every U agency have. So for the donor purpose, we have linked our DHIS2 through API to our Power BI dashboard. So our donor can have easily access to it, because you know that the data used for the donor at that level, that how to get the data, how to extract the data, how to know. So we have linked our DHIS2 through API with our Power BI dashboard. Shortly, I will just show you quickly the dashboard also. So I'm quickly just showing. Sorry. Okay. Can you help me with the keyboard? Sorry, it's a kind of It's good. It's good. It's good. So we have a couple of dashboard. We have done all the part of creating indicator for our analysis, and we have a couple of dashboard, a general dashboard which are showing what is the number of beneficiary that we are reaching at the community level, and also we are capturing this information by demographic. Like the host community, Afghanistan are facing internal displaced people and also returnees. So we are also tracking by indicator the services that we are providing, all those information. So I'm just quickly going through, so I don't take much time. So we have all those information, and also beside that, we are also capturing PWD people, the services that we are providing to people with disability. So we are also capturing that. So we have like this is 2024 report. So the number of beneficiary we have reached, PW beneficiary we have reached, and also the map we have used. So we have utilized all those services. And as you can see, we have a different level of access to our user, to our implementing partner. For the humanitarian, as you can see, we have a separate dashboard for humanitarian, and we have a dashboard for population. We have also integrated psychosocial service, because the context of current of government, the GBV is kind of a sensitive issue. So we have converted to psychosocial services. So we have over 110 service delivery point or clinic where we are providing psychosocial support to women by women. And we just changed the name to psychosocial support. So the service is almost a psychosocial support to all the target beneficiary. So reproductive health and all those. So coming back to the slide. So this is the one we have done in DHIS2. And in the Power BI, I will just quickly go through that. So we have linked our DHIS2 to the Power BI, because that is easy. They don't need a login, and just easy filter. We have put it there, and we can see easily this is the target audience for this is a donor. So they can see what is the target population in Afghanistan which is in need, and also the reproductive women and currently pregnant women. If I come here to another part, so we make it very easy for the user or for the end user. So they can filter by year, by month, by program, by province, by donors, by IP, which IP. So they are easy to switch between the data, get the data, share the information, or even validate the data when we are providing report to our donors. So this was just a short view. I'm going to the next one. So what is our future plan? This is very important, and I want you to support us, all the HISP community in Asia and also Oslo. So now our next target is we've already achieved aggregated data. So what we are planning to do is we want to ensure that all UNFPA facility are connected with internet connection. One thing. Another thing is we would like to collect individual level data. So now we are collecting aggregated data, but we want to collect individual, who is the beneficiary, with very basic information, but individual, and for what purpose they have visited. Because most of our beneficiary are women, over 80% is women. You can see the link of Power BI, you can see play around the data. I think it will be shared shortly. So, and also one of the most important part, we are providing immunization service in this delivery, and they have that immunization freezer. So we would like to connect that freezer with our system DHIS2, so we can get the real-time information that what is the status of those freezer. Whether it is within the threshold, the temperature is above, the temperature is low, whether the facility have problem with the immunization freezer, so they can notify us on that. And one of the challenges that we are facing at the moment, we are thinking about that how we can address that, is the real-time data. We are calling DHIS2 because the analytics run maybe in 6 hours. We can schedule it in 24 hours, but minimum we can schedule it in 24 hours. But how we can get the data in the real time? Because we are connecting all the service delivery point, and we will be providing all the equipment. We are planning for tablet to provide all in the facility, and we will be training them. And we will be, once the beneficiary has been added, it should show on our control room so we can know what is the number we have reached. And most important part is how we can have the information and the immunization freezer. So whether if it's not functioning, we should know, and we should contact and support the area or that SDP. And if it is above, if it is low, so how we can do that. So this is our future plan to have those implemented. So I was just very concise, sorry. I just wanted to have some session for a question and answer. And I will be reaching you out so we can see that what will be the solution that we are planning next.
Thank you. Yeah, no, concise is good. A round of applause. Yeah, concise is good. We would like to get to some questions. So are there any questions or even comments? Because there are a few questions that you had as well, so.
Thank you very much for a very good presentation and having us an overview of what actually UNFPA is doing in Afghanistan and how UNFPA program has transformed to DHIS2. But you know, in Afghanistan, we have so many districts and health facilities and so many partners and donors. Like UNICEF is supporting health facilities, maybe other organizations. So, I mean, do we have a plan in Afghanistan? This is a very general question, not specific to your, to transformation at the national level to DHIS2. Because what you have presented is basically what UNFPA is doing, that is converted. So other organizations or other health facilities at large, What is the situation of transformation or transitioning to DHIS2 in Afghanistan at the national level, not specific to different partners? Thank you.
Thank you so much, Inam Saib. This is why I've mentioned early that I'm presenting what UNFP Afghanistan is done in implementing. But thanks for asking this question. Afghanistan have implemented DHIS2 at the national level in 2016. So we had implemented DHIS2 at the national level, which I have mentioned, even the SDP that we are supporting also reporting to the national HMIs. So we have at the national level where every service delivery point or every facility have to report their standard aggregated report monthly, or we have for COVID-19 response, we have a surveillance, and we have for other immunization purpose. So we have a very detailed DHIS2 implemented in Afghanistan. I think that will take much longer, so I can go through it. This is why I just focus that why, and why we are. So maybe the next question will raise that why we are implementing our own. So there's two reasons for it. One reason is the current government. So the way we are implementing it, so we would like, because mostly we are delivering services to women, and especially in gender-based violence, psychosocial. So we don't want to share the information because they may affect our implementation. The next thing is that the aggregation that we are collecting, like as mentioned, demographic we are collecting, the level of IDPs, returnees, and also PWD. So at that level, the information is not available. At that disaggregation, information is not available in the national HMIs because they have another disaggregation, age disaggregation. We also have age disaggregation beyond that. So Afghanistan have implemented DHIS2 almost 7 years ago, and it's been abroad at every level. Even we have implemented at the private hospital, it's planning now, implemented at all levels. Thank you.
My friend, my question concerning Power BI, is it online connection or offline? Power BI.
No, it's online.
It's online.
It's
huh?
online. I hope they will share the presentation. And one thing is important to mention because this is over for a donor purpose. This is why I've just presented here. So the Power BI is online. They don't need any credentials. So this was the reason for a person who is not used to the DHIS2 how to get the information, like but different category, different dimension. So we made them easy for it. So they can just filter and get exactly the data which is available on DHIS2.
This is good to have this experience to be published to everybody to know how to do the connection with the Power BI.
Yeah, so certainly I know other countries have attempted to do that, to link. My colleague was just saying that it would be good to have that experience about how to link to Power BI. But I know in some countries they link to other external platforms as well. Yeah. Any more questions? Or did anyone else have a comment?
I would appreciate any comment for the last part or next plan. I would really appreciate that.
Okay, well, if there's no more questions or comments, another round of applause. Thank you. That was a very interesting presentation.
Thank you. Thank you.
And that's it for this session. I'm going to hand back to Anu, and yeah, I think we're almost at lunch. So over to you.
Yes, so thank you, Michael, and our presenters for an insightful session. So before we going to lunch, if you have any more questions for our presenters, or if you so please reach out to them, or if you have any more questions on the conference itself, you can also reach out to me, Nia, and Sam, the MCs, if you have any question at all. So, yeah, so I would like to invite all our participants to the lunch break. Our afternoon session, which is the parallel sessions, will start at 1:30 p.m. So please enjoy your lunch and come back to the conference room before 1:30 p.m. Thank you. Yeah, so a little bit about our parallel session in the afternoon. So for the data quality session will be held here And for our system integration will be in another room. Yeah.
Okay, everyone, hello. I think we'll get started with the session now. So this session is going to be divided into two parts. So I'll start the session and I'll review some of the data quality measures along with our data quality toolkit that we have available. And then I'll invite my colleague Jason up to the stage as well, and he'll talk about metadata assessments and a little bit of work and information on how you can have a look at the kind of health of your system's configuration. Okay. All right, so in the data quality part of this session, we're going to go through a couple different pieces of information. We're going to start with an introduction, just a bit of background on what's available in the data quality toolkit. Then we'll talk about some of the metrics that we have available. Some of the metrics we have are fairly new, at least in terms of how they're implemented inside of DHIS2. And some of the metrics are kind of the tried and true tested ones that have been available for some time. So I'll do my best to differentiate between what's new and what's been there for quite some time. And probably if you're familiar with DHIS2, you might be familiar with some of those measures. We'll also discuss the Data Quality Annual Report app. So this has been kind of built to replace some of the functionality found in the WHO Data Quality tool. So for anyone who's been using that previously, we had a function within that tool to create an annual report. Now we have a separate app, a new updated app that has been made in order to take many of those features and build upon those, and I'll demonstrate that. And then I'll discuss some of the implementation tools and considerations that are available for you to utilize. Okay, so we'll start with an intro. All right, so first I just wanted to give a bit of an overview of what the Data Quality Toolkit includes. So we have a new set of documentation, and I'll open that in a second and walk through it with you, that gives you an idea of how to configure all of the new measures that I'm going to talk about, how you interpret some of those metrics and measures, and also how to utilize those in your own systems. We also have a demo that's been set up that you can log into. It's publicly available in order to view all of the various metrics that I'm going to discuss on a live DHIS2 implementation. We do have some of this configured, and I'll go through some of that and walk through some of that with you today as well. We have a couple tools as well that are available for you in order to help you kind of set things up or move things forward. So like I mentioned, we have this new annual reporting tool, new annual reporting app, I should say, that is in line with the WHO Data Quality Framework. And we also have this script for generating minimum and maximum values. I'll come back to that in a moment. There's actually an additional tool. It's not on this list, I apologize, but there's a tool to also support some of the configuration of this because the configuration is quite heavy in terms of setting this all up. But once it's set up, it's all automated, which is nice. We also have a standard operating procedure template to help you kind of, get this actually implemented in your own settings, have an idea of at what various levels, what should people do in terms of reviewing data quality, what should be taken, what actions should be taken when you find an outlier, for example, or a value that's incorrect, And the idea is to give you an idea of where to start. It's not meant to adapt necessarily one-to-one in the country you're working in, but it's meant to give you some tools that you can utilize in your own countries, as a reference or a template and build upon that. Okay, so the data quality toolkit itself that we're focusing on largely builds upon what's available in the WHO Data Quality Assurance Guidelines. And that guideline is split into a number of different modules, right? So the one we're mostly focusing on is what we call the desk review portion, right? So this is the portion where basically the data has already been submitted and you can have a look at the data in your DHIS2, okay? A new part of this that we're introducing relatively soon is on the supervision aspect. So that's a different module within the Data Quality Assurance Guidelines. The supervisory tool is where you go down to the facilities and compare your data that's been collected in your system versus what's there in the actual registers, et cetera. Okay? So we are working on a tool for that, but for today, we're going to focus mostly on talking about the desk review portion of our data quality toolkit. Okay? Yeah, I can skip this one. All right, so just quickly, for anyone familiar, it really looks bad on the screen, huh? So for anyone familiar with the previous WHO data quality tool, we are shifting and moving away from that. That is not receiving any more development support. So I know that there are some countries who had used that quite a bit in the past, but what we've done is basically move most of the feature set that's available within that WHO data quality app, and we've kind of built it into our own core DHIS2 platform. There's a number of reasons behind this. I mean, on large systems, for example, that WHO data quality tool didn't really scale well. You know, so for example, I was doing some stuff in Nigeria, it just crashed all the time. So we wanted to make sure that we got these metrics into our core so we wouldn't have this scalability problem. Also, so we could add everything to a dashboard. That was the other issue with the WHO data quality tool. It was just contained within that tool itself, and you weren't able to add those to a DHIS2 dashboard. So there's two areas right now where we don't cover within the kind of core tools. There's this very specific type of scatter plot, as well as the annual the generation of the annual data quality report. But we have an app, at least for this one here, the data quality report, we have an app built to deal with that. So while it's not in the core, there is an app that supplements the functionality to allow you to generate this report on an annual basis. And I'll show that. Okay. So what I want to do now is just go over some of the metrics that are available and just review them real quick. All right, so I'm going to walk through some of these and just display what they are. So any of these metrics that are starred, these are kind of relatively new, at least in the DHIS2 space. Okay? You couldn't really calculate them easily, I would say, previously, right? Some of the stuff is there from before. We had validation rules, we had min-max values, and you had your data set reporting completeness and timeliness available. But now we have a number of new metrics that you're able to calculate and review, you know, once they're set up on your own system. And we'll spend a bit of time walking through that, just displaying what they are, explaining them a little bit, and show you some examples inside of DHIS2. Okay, so the first thing I'm going to talk about is validation rules. Now, many of you might be familiar with these, okay? But just as a quick review, right? So validation rules, they have a left side, a right side, and an operator of some kind. You can analyze them at the point of data entry. You can also analyze them as a batch set, for example, in validation analysis. You can perform, these are configured in your own system, right? So while we have a lot of references you can look at, you are able to configure these to your own needs. The nice thing about validation rules, they support various types of consistency. So you can look at internal consistency, where you're just comparing variables, let's say they're collected on the same data set. But you could also compare internally collected data with data from some other source, as long as that data has been imported into DHIS2. For example, if you want to compare a certain data element with the same data element that's been collected on a survey, right? Maybe ANC1 coverage or ANC1 visits that's collected on a DHS versus an ANC1 that's been collected in DHIS2, okay? DHIS being the Demographic and Health Survey, okay? So you are able to use this in quite a different number of ways, but I'll just show some basic methods to explain. Okay, so here's our tried and true data entry app, okay? And when we want to check validation at the point of data entry, we'll just click on Run Validation. Now, all these rules have been set up already, right? But if I have some basic checks at this point of data entry, and it gives me some information back that I need to review, I can obviously go ahead and fix some of these if I need to. So this one here I'm going to fix, and then it should remove that ideally. Now, ideally, you would have some SOPs, standard operating procedures, in terms of what you do when you encounter these types of errors or messages, right? And we know there are some limitations, right? Sometimes the data entry person may not always be able to change that data or fix that data. But the idea is to prevent as much kind of challenges kind of going up the system, and we'll see why that's important later on when I talk about outliers, et cetera. But the idea is to kind of be more preventative rather than reactive to these problems. So just real quickly, I'm going to fix one of these. Okay, and then run it again. Okay, there's still some errors. I didn't fix them all, but the one that was there has been fixed. So the idea is to try and reduce the amount of entry errors that are submitted from the point of entry as much as possible. Okay, okay, so doesn't like when I shift. Okay, so the other metric I really wanted to quickly mention is min-max. So this is something that's been around for a very long time as well, okay? And what we can do is basically define minimum and maximum values for every data element, disaggregation, and organization unit combination in your entire system, okay? Now, there are issues doing this inside of DHIS2, and we really don't suggest that. We, however, have some prototype tools that we'll be actually testing next week in Lao to help you generate these minimum and maximum values to be much more accurate. So we're going to test that out and see if that's something we can basically help you guys with a bit more going forward, okay? And I'll just touch on this real quick. Okay, so let's say I enter a value. Okay, so I've entered a value, and maybe I just kind of entered a quick value, and maybe I made a mistake when I was entering my data. It gives me a message that the number cannot be less than 0 or more than 100, as an example. So in this case, there is a maximum threshold of 100. And what I can see, so this is the new data entry app for those of you who aren't familiar, just to quickly show it. Okay. What I can do, I can view the details of this field. Hard to do this with one hand. Okay. Okay, and I can see that there's a minimum and maximum. Just zoom in. Okay, there's a minimum and maximum set for this particular data element disaggregation and organization unit. Right, so we can see here I'm entering data for MR1. It's less than 1 year for this particular organization unit. Okay, and that's why it's showing me this issue with the maximum value. So I could change this. Let's say it was supposed to be 24, right? Then I will no longer receive any error when I enter my information, okay? And the whole idea is to generate all this information, not necessarily enter it manually. That will take ages and ages and ages. But if you're able to generate these minimum and maximum values and bring them into the system, this can really help, once again, with any kind of obvious error where a person's maybe hit their keyboard one too many times. It can help with correcting those types of things. Okay, so we've gone quickly over min-max and validation rules, and I just showed validation rules at the point of data entry. You can also analyze your validation rules in bulk, right? So this is the validation rule analysis. I've set everything up. I've selected my org unit, my dates, and what I want to run. I've also taken this send notifications button, which you can have done automatically. There is a facility within DHIS2 to send out notifications when you detect a validation rule being broken, essentially. Okay, so I'm just going to run this quickly. I'll click validate, and I apologize, it's a bit hard to see on the screen. Okay, and it's given me my output. And for the parameters that I've set, I can see that there are a couple of validation rules. It's not an overwhelming amount, which is actually good, because I could probably go in and fix these pretty quickly. But the idea is that there are some values that need to be fixed. It gives me the organization unit, it gives me the period, I know the data set that it's associated with based on the messaging that I've received. Okay, and I've also received an email here. It's very hard to see, unfortunately, nearly impossible. Okay, but I've received an email here that gives me what these validation rule violations are. And I'm able to schedule these, so I'm able to receive these directly. So if you have people who aren't regularly maybe getting into the system, so I have these kind of messages that I can send out in order to notify people of this. Now, you have to be very careful with these messages, because you don't want to send out too many, because then people will just start ignoring them and thinking it's junk, right? So you have to be very kind of meaningful with whom you select to receive these and how often they're sent out, etc. Right? You want to make sure it's just going to the right people who are going to follow up on this. So while there are a lot of tools, it doesn't mean you just kind of implement everything. You want some procedures, as I mentioned, to maximize kind of the value that's being achieved from these various tools. Okay, so now we can talk about some of the metrics that we have in DHIS2. Now, this is still kind of the old stuff, right? So min-max, validation rules, and data set completeness and timeliness. This is all stuff we had for a very long time within DHIS2, right? So none of this is necessarily that new. Right. right? So we have completeness measures that show us, the completeness of our entire data set. We also have these timeliness measures, which are self-defined, depending on, let's say you say timeliness is 15 days after the end of the month for a monthly data set, then we can evaluate that as well. But there's a lot of issues with this metric, okay? Because it's just taking the entire data set as a whole, but you don't know what's happening with the values within that data set, right? So there are some new metrics that we've recently introduced regarding completeness. So we have one called data element completeness, and we also have one organization unit completeness, or maybe it's easier to understand, facilities consistently reporting, okay? So data element completeness, rather than looking at the entire submission of the data set, is just looking at individual data elements. Okay, so let's say I look at BCG doses. For the last 12 months, how many in that one facility did they report their BCG every month or not? And if they didn't, then there's a percentage of completeness that can be calculated. For this one here, facilities consistently reporting, or organization unit completeness, this is also looking at the totality of various variables and how often or frequently they've reported within a 12-month period. You mark a facility as being complete if for the last 12 months, if they've reported every month, right? So let's say that facility is expected to report a value every month, right? Then did they or did they not for the last 12 months? Okay, so we have some examples of this on the dashboard here. You can see data element completeness for a number of data elements, IPv, DPT1, et cetera, right? I'll go over this example a little bit more as well, okay? And you can also perform some ad hoc analysis on this as well to just get completeness of, for example, an entire data set. I don't recommend putting that on your dashboard, but you can go into pivot tables, for example, and I can select all the data elements in my data set, and then I can make a chart, just quickly say, are they complete for this month? In an ad hoc manner. This is more the automated analysis that is set up, maybe to do a review a bit more frequently. Okay, so. All right, so what I have is a table here with data element values submitted for DPT3. Okay, and I just want to clarify how some of these values are collected. Okay, so let's just highlight one row here. Okay, let's just highlight this one row of data. Now, if I'm evaluating data element completeness for any 1 month in this facility, it would be 100%, right? Because they've submitted something, right? Okay. If I look at the other metric, facilities consistently reporting, they would also be marked because they've reported a value for all 12 months, okay? So one value is just looking at a singular time period. The other value is looking at a span of 12 months, right? But if I look at maybe another facility here, okay. In this facility, we have 2 empty boxes, right? So their facilities consistently reporting. They wouldn't be marked because they're not actually reporting any data for 2 of the months out of that 12-month period, right? And their data element completeness for this month and this month would be 0, right? Because they haven't reported any data, even though they're expected to report data. Now, there could be a valid reason for that, right? Doesn't mean always that something's wrong. But typically, the idea is you select variables when you're doing this analysis that they're expected to report on every month. You wouldn't select variables, ideally, where there's kind of intermittent reporting happening, right? Yes?
Sir, I have a question over the data completeness. I mean, there are some situations like a facility cannot complete the total data set. Some of the areas are not related to his health facility, means EPI. EPI, if the EPI facility is not available in the that facility, but he has to complete the same form. So we have the same form. So his data is complete technically, but not completed. All the fields are not filled. How can you counter this? I mean, sorry. I mean, in DHIS, we had that this field is not applicable to me. If I click this option, then my data is complete. Is there any DHIS2?
Yeah, I mean, in terms of data set reporting, there's not a whole lot you can do because everything's on the same form, right? But here you can kind of drill down and select specific variables that apply, right? And say, okay, every month at least, I know there should be data in these specific variables. And they could review those on a monthly basis, right? Because you're saying there's only certain variables that apply to them, right? And I guess that's kind of a broader group of users, right? Not just one user. Okay, so you can select those specific variables and maybe make a dashboard and say, okay, every month I know that these, let's say 5 core variables, there should be data, right? So at least let's review these 5 variables and see if there's data every month or not. And if there's not, then there's probably an issue and we need to check what's going on. So that's kind of a way to combat this issue with data set completeness, which runs into some of the problems you mentioned, like not everyone filling in the full form. Yeah. Okay. Okay, so we've also introduced some new chart types. This is maybe if you're familiar with the WHO data quality tool, you would have seen this. So consistency of related data, we can use scatter plots. We can also use dropout rates for those of you who are familiar with that measurement. Okay. Okay, so here's an example of some of these scatter plot tools. There's not a really, I mean, some of these vary a little bit, but nothing really concerning, I think. But these are kind of analyzing, you know, 2 related variables on these scatter plots, and there's kind of a predictable pattern that should occur. In these examples, we have the one I'm hovering over is OPV1 and OPV3, right? So there's kind of an expected relationship between these 2 variables, and if the variation between the 2 is very high, then it'll kind of outline these. Now, there's a little variation going on here, but basically if anything's in these big boxes up top, then those require a bit more investigation in all likelihood. Right? We also have these dropout rate charts, and some of you might be familiar with this. You can apply them to several programs, right? We see some negative dropout rates. They're highlighted in red. Just zoom in, okay? And generally speaking, these negative dropout rates over a kind of longer period are not really possible, right? So these would require investigation to understand why is my dropout rate negative, right? Because typically, that's not really the case. Okay. Consistency over time, this is another metric that you'll see. We have these what we call year-over-year charts, okay? But they're basically just histograms showing, or kind of these kind of charts that are showing you previous year's progress and comparing them with one another. So you'll see this on this example dashboard as well. What these are really good for is pointing out very obvious errors in data, right, where patterns are kind of consistent. So I'm just going to hone in on one chart right here and open it up, okay? Now, there's a lot of lines here, and it looks a little messy, right? Basically, one line represents 1 year of data. And we can see that, and the bottom, the x-axis here, these are the months, right? But we can see the data is kind of clustered together for the most part, but then up there you have this point that's kind of away from all the data, right? It's very far away from the rest of the data and doesn't really follow the pattern. Probably some type of data entry error was made. Nothing sinister likely, but it's a pretty obvious error there. If I hover over it, I'll see. This is 28,000 for January 2020. If I find 2021 here, so the value is only 9,500 for 2021, right? So there's quite, someone's entered some data incorrectly somewhere, right? So you pull up a pivot table, you could kind of drill down, you could investigate the source of this, and you can figure out what's going on, okay? So anytime there's obvious errors, these really help. And you can set them up for a couple core variables as well, just so you can kind of quickly log in every month and determine the variation that's occurring. All right, outliers is another area where we spent a lot of time implementing into the core feature set of DHIS2. So there's a lot of stuff going on in the WHO data quality app regarding outliers. The only problem was you needed to understand the terminology, right? It asked you to apply filters to areas such as Z-scores, right? It had both a modified Z-score and a regular Z-score. And if you didn't really know what that was and you started applying these filters, it kind of got a little hard to interpret, right? So the idea is to identify these outliers to the person rather than them having to think through the math. Now we have some tools if you want to get into that detail and look at kind of the variation yourself and determine what's going on in a bit more kind of investigative manner. We do have tools for that, and I'll show those quickly as well. But the idea was, let's just show them what the outliers are so they can fix them, right? Let's show them the facility, let's show them the month, let's show them the value, then they can go and change it or investigate why it's so high or low. Okay? So we have a couple of various measures for determining or looking at outliers. So the first one we have up top is kind of these values called excluding outliers. This is the percentage of data for a 12-month period that does not have any outliers. Okay? And I'll open up a chart and I'll explain this more. So for example, we have a value here, BCG excluding outliers. It's saying 91.6%. So this means that 91 or 92% of the data for BCG is not an outlier, right? 8% of the data is an outlier. Okay? And what we've done is also create measures to give you a bit of a holistic look at this. So on this column here, on the right column here, BCG doses given, this is the actual amount of BCG doses recorded inside of DHIS2. Okay? This column here is the BCG doses excluding the outliers, right? So basically, if an outlier value is identified, we've removed it from the aggregation, and we're just showing you the data minus the outliers, okay? So to calculate this percentage, we take this column, divide it by this column to give you this value, okay? So that's how these work, more or less. And the idea is to give you some idea of how much are outliers affecting your data. Now, it's not too bad in this demo data here, right? In some live systems, can be a little worse, right? But here it's not too bad. It's fairly accurate. Okay. There are also kind of a number, so yeah. So what I was saying here, so what I was saying here is to just give people the outliers so they don't have to kind of think about the math too much, right, and investigate why they're high. So this is actually a table that's just giving you the outliers that have been identified. So for this value, DPT1, September 24, we have this value of 198. It's an outlier and it needs to be potentially fixed. Maybe not for sure, but it's worth investigating, right? So the idea is just to give you those values and then you can investigate them. Now, if you do want to get into the math a little bit, let's see how big I can make this before it doesn't want to play nice with me. Let's see. Okay, so this is an outlier table. Okay, it's a new visualization introduced in DHIS 41. And this shows you basically, if you're familiar with the WHO tool at all, and you ran the outlier analysis, it would give you this table, okay? And what it shows you is the value, the median, right, which is the midpoint of the data set for all these values in this particular facility. It shows you the modified Z-score, right? This is a method of calculating variance, okay? The deviation, the min, and the max, okay? So if we have a look at this value, it's 854. The median value is only 9, okay? It's very low, right? So we have this huge kind of increase for the value that's been recorded for that particular facility, for that month, for ANC4, right? Chances are it's incorrect. It probably needs to be fixed, okay? So this is kind of a tool to help you look at these in a little bit more detail. And it's very easy to make. It's just a new visualization in DHIS2 version 41. We have this outlier table available in the data visualizer, and it basically allows you to really quickly build these tables. You don't have to input all the various statistical calculations. You just select your variable because the outliers are calculated by the analytics in the background. Okay? Okay. We also have this, so that kind of concludes the kind of core metrics in DHIS2. You can see there's a lot of new kind of potential measures or metrics you can implement to check your data. Of course, that's why we also have this SOP template to help with the implementation part of this, because just enabling all these tools, as neat as they might be, unless this data is kind of being viewed on a regular basis, then there won't be much happening necessarily with the data. Okay, we also have the Data Quality Annual Report app, and this is meant to fill that void of the WHO data quality tool, which previously generated a report for you. Okay, so we still focus on the measures that are within the WHO data quality assurance guidelines, right? Completeness and timeliness, internal consistency, external consistency, and consistency of population estimates. Okay, I think the easiest thing is to just show it. Okay. Okay, so this is the new version of the tool. It's available on the DHIS2 App Hub. It supported quite a few versions back, I think all the way back to 38 or 39. I'll double check, but it is there. Just with a couple clicks, so you do have to configure this tool. So just like everything else I've been showing, there's a lot of configuration involved at the beginning. So there's a bit of an investment, but once that configuration is done, everything is automated. So it makes it a little bit easier, right? You can just log in and view the dashboard, log in and make an annual report when you need to for the various metrics that you've covered. And it covers those domains that I talked about here. It's a lot of different information. Okay. One thing that's maybe interesting that we didn't talk about previously, this panel here, this is an external comparison of data, right? So here we have, it's a little hard to see. Okay, but it's comparing routine data from the EPI that's collected on a monthly basis with a demographic and health survey. So data has been brought in, okay, and it's showing the variance between these two data sources. This is something you can do in the core tools as well, but it's very nicely done within this annual reporting application, right? So the triangles, blue triangles represent the routine data that's in DHIS2. The red triangles represent the demographic and health survey data that's been imported into the system. And we can see that there is some difference in values at the different kind of levels of the system. Now with this report, you can also add in kind of your interpretation of all of this information because you are able to print it out later on, right? So there's a print button here. So once you add in your interpretations, you can print this out. You can either save it as a PDF or print it to an actual physical printer and get the printout, okay? And then you can disseminate that if you need to. Okay, so. Okay, so just real quickly, before I hand over to Jason, I'll go over some of the guidance we have available. So there's links to all of this in the presentation. So the guidance goes over a number of pieces of information for you. It discusses general principles around data quality. A lot of this is adapted from the Data Quality Assurance Toolkit. We talk about various features that are available in data entry, so validation rules, min-max, for example. All the analysis features, and there's quite a few. And there is also all the various parts of the configuration that we talk about as well. So unfortunately, the configuration is a little complicated, but we do have some tools, like I mentioned, that help you configure these. So you just kind of can click a couple inputs, and it'll help you to configure these as well. Okay? But if you want to learn the kind of nitty-gritty details, we do have all of that available, as well as how to interpret all these measures. Okay, another thing we've done is create a checklist to help you along in terms of preparing to implement this. So some of the things you need to talk about with the ministry, some of the measures you might want to decide on, talking about some of the configuration steps itself. We also have various toolkits and guidelines for this. So for example, here, we have a very long configuration document, but if you just want the summary of all the steps, we also have quick steps in terms of if you want to replicate these dashboards, etc., what you would need to do. The idea is just to give you a place to start. Like if you're wanting to implement this in your own country, how do I actually get started and get moving? Right? Okay, I also mentioned this standard operating procedure template. Okay, and once again, this is not necessarily meant to be taken and used one for one in your country, but it's meant to give you some idea of what an SOP might include. And what we've tried to do here is outline at the various levels of an example health system. Obviously, the names for hierarchy levels in your own system might be different, but service delivery, health districts, regions or states, national level, what their responsibilities might be, okay? And then talked about some of the measures in terms of how often they're reviewed, okay? And some of it's a little blank because it's meant to be defined. We have some instructions that accompany this as well. Okay, and then lastly, we have a subnational checklist. So this is maybe meant to be deployed after you've done a training, let's say, and you want to follow up on if there's any type of behavioral change, right? Are they actually doing what you've asked them to do, right? Are they reviewing the data on a monthly basis? Are they checking the metrics that you've asked them to? Are they following the proper reporting procedures when they've identified an outlier or an incorrect value? Are they fixing those values, et cetera? Okay, so that's what this is for. Just to kind of monitor if the training or the implementation that you've performed is actually kind of proceeding the way you want it to. Okay, so the demo that I've showed all these features and everything, it's available on this link. This presentation is uploaded for you, so you can always access this. The login details are on the front page screen. You can log in, you can have a look. There's a couple dashboards that are configured there. Okay, and of course, if there are any questions or anything, I'm happy to help you out with over the next couple days that we are together, and after this as well. All right. So I know that was a bulk load of information in a very condensed time frame. I apologize for that. Maybe I have time for a question or two before I hand over to Jason. Yes.
Yeah, thank you for the presentation. I think it was very great. So I have two small questions. One, why in the data completeness in the data set, why the validation, how can we link the validation with the completeness? Because sometimes the data entry officer not validating the data. And if the data is not validated and they click on the complete, so the data is completed without validation, one. Another, I don't know, I think I missed it, how to fix a min and max value. To be implemented for all the months they are reporting for all the type of facility. Yeah, so thank you.
Sure. So, okay, yeah, the validation rule one is tough because when they, as of right now, you can't stop them from completing the data set if they haven't run the validation checks, as of right now. I don't know if that's something we're going to change. The challenge that we have in terms of adding that as a generic feature is that there are many instances where they can't fix the value. So even if they run the validation rules and we don't allow them to submit, they can't fix the value, so then the data set never gets completed or submitted, depending on the workflow. So I don't know if it's something we'll support generically. It is probably something you can do as a custom modification, but supporting that generically might be tough on our end. I can talk to my colleagues and see if that's something we'll think about, for sure. It's good feedback. But as of right now, I know we don't support that. For your next question about the min-max, yeah, so okay. First thing I would say, DHIS2 has a facility for generating all this, but like I said, don't use it. It's not helpful. It'll give you incorrect values. We have a prototype tool that we've developed to create min-max values for all your facilities, across your hierarchies, across all your periods. We're testing that actually next week in Lao, and we're going to see how it goes. And if that's something that works, we're going to release it for the public, and they can use that to help them generate min-max values. But for now, yeah, I guess just wait. But we'll hopefully have some more information within a month or two after we've tested it in Lao and can share that with you. But yeah, unfortunately, the facilities inside DHIS2 don't really work very well. So I recommend not using that. You can either use a statistical tool outside of DHIS2 or wait until we release this application. That would help you make those minimum and maximum values. Okay. Any other questions? Okay, if not, I think I'll hand over to Jason. If there are any other questions, please feel free to grab me at any time. I realize it was a lot of information. But yeah, we'll hand over to Jason, and he'll talk to you a bit about how you can assess your metadata.
I think so. Yeah. All right, let me see if I can get this away. Okay, so I think we're almost there. Get rid of this thing here. All right. Good afternoon, everybody. I'm Jason Pickering. I work with the Global Implementation Team. And today we're going to talk about the brand new metadata integrity checks that we've developed recently. We spent quite a lot of time on this, working together primarily with other members of the implementation team and the development team to redo a lot of the metadata integrity checks. There's also some checks on data as well. Some of you may have used this feature in the past and probably had issues with it. You may have even crashed your server with it. It was very slow and often didn't work in very large instances. So we've done a lot of work cooperatively between the implementation team and the DHIS2, both the back end as well as the front end team, to completely redo this part of the application. And I think it will be very useful for many of you. So yeah, as I mentioned before, the previous integrity checks were all Java-based. They were frequently very non-performant and very memory intensive. This really depended on your system. You know, if you have a very small system, they probably work fine. But in many very large instances, and particularly old systems, and by old I mean systems that have gone through many upgrades over the years, we often saw issues, both in terms of load on the performance and some cases even crashing the entire system. Another big problem was that, it was not possible to selectively run individual checks. So if you were only interested, and this was often the case, you might only be interested in running a particular check at a time, because if you have like 50 different problems with your metadata in the system, you can't address all of them at the same time. So oftentimes you might be looking at organization units without coordinates, and you don't want to have to rerun all of those checks all over again. You might be only focusing on that specific problem. So that was a big problem. There was also what we've seen over the years, and as we've worked with a lot of countries and other organizations that are using DHIS2, there were a lot of checks which were missing, a lot of problems that people had told us about, things that needed to be checked which weren't implemented. And this was quite difficult because it was all written in Java. We needed to get a Java developer, it needed to go on the roadmap, and it became very laborious for us to implement these types of checks when we found them working with you guys, for instance. So as I mentioned, in version 40 plus of DHIS2, we've completely rewritten all of basically the entire subsystem. For the most part, there are still a number of these integrity checks that are Java-based that we cannot rewrite in SQL. At least I can't. It's not very straightforward to do this. So some of them we've left in Java because we need to, but the vast majority of them have been rewritten using SQL, and so they operate directly on the database and tend to be very, very, very quick, certainly much quicker than they were before. We also wanted to make these relatively accessible to database administrators or DHIS2 administrators. So we wrote them in a format called YAML, which is, some of you may know this, is yet another markup language. It's similar to JSON, similar to kind of a web-based format, but it's a little bit more user-friendly. I'll show you an example of one before. They're sort of human-readable if you're familiar with databases. It may not be for everybody here, but we did want to intend it at least for people that are familiar with executing SQL queries on the database. And so instead of having to go through the front end, it might also be something that a database administrator or DHIS2 administrator could do directly on the database. And that could also speed the process up a little bit. Another really great feature that one of the back-end developers had suggested was extensibility through custom checks. And so we have written 60 plus or so metadata integrity checks that we believe are basically applicable to all DHIS2 systems. This is sort of opinionated, and we certainly would value your feedback on whether you think that it's applicable to your system or not. But we know that there's definitely also a need for implementations to include metadata integrity checks that are specific to their specific instance. It may not be applicable to everything. A good example of this would be data element naming conventions. So you may have established a certain way of naming your data elements. I also know that a very common practice in the past has been to append the, let's say, province code to the name of the organization unit. That was very common in Southern Africa and in DHIS 1.4. It's another naming convention, and there's no way necessarily to enforce that with DHIS2, but it may be something that you want to check in your own instance. And so there is a way basically for system administrators to create these custom checks that may only be applicable to your particular instance. That's not necessarily applicable to everyone. If I'm going too fast, something isn't clear, feel free to stop me and ask any questions. We gave a much longer workshop on this a couple of months back at one of the academies in Addis. I did want to include this slide though, because I think it helps to give us a bit of context into what some of the root causes of metadata integrity issues are. These checks only help you to identify them. They don't necessarily, from a sort of technical perspective, what they don't do is to help you to address necessarily all of these problems, right? We wanted to give you a tool to help you to easily identify them in your system. But there's many other factors that you may need to consider in terms of why these certain metadata may be considered to be invalid or problematic. One of them, of course, is the change in the DHIS2 metadata model over time. So as the system has evolved, There have been changes, various changes to different types of metadata organization units, data elements, indicators. So particularly if you have a database that is, say, 5, 10, 12 years old, you may have gone through many upgrades over time. And what used to be valid may not be valid anymore, basically. Or you may be missing something in your database. So some of these checks will help to identify those issues. If you're running a very new instance, something that you created over the last year or two, you may not suffer from this type of problem. I don't really know what I meant by changes in the DHIS2 instance over time. Maybe I'll think about what that is. One key problem is the weakness of the validation during import. So there are many things that the metadata importer doesn't necessarily check for. I think a good example of that would be the naming convention. So let's say that you're creating a new data element and you've decided that it should have this specific naming convention. The generic DHIS2 metadata importer doesn't know anything about that naming convention, basically. So over time, these types of issues may add up. There are many other weaknesses, basically, in the importer. A lot of that has been improved, particularly over recent releases. It's gotten a lot better, but it's still, there are issues, particularly between metadata objects. Where relationships between certain objects may not be caught once you've imported the metadata into the system. Another sort of systematic, this doesn't really have anything to do with the software per se, but a lack of standard operating procedures in how metadata is managed. What we've seen in many instances, particularly ones that have been running for a long time, is that there's a lot of cobwebs in the corner, if you will. There's a lot of like dust that is collected over the years. And so there is kind of a tendency to add new data sets, add new indicators, add new dashboards, but perhaps less emphasis on cleaning up the old stuff that is no longer used, or worrying about how do we migrate our old metadata to our new metadata. And so this can have an impact in terms of system performance. As you collect more dashboards, as you collect more users, more metadata objects, that can have a deleterious impact on performance. Unfortunately, we've also seen in many cases where there's been experimentation or training which has been conducted on production environments. This is, of course, something that we would strongly discourage and would definitely recommend that you should always use a development, testing, production type of workflow where all of your changes and experimentation and training are made in something other than production, but we know that in many cases that may be the only instance that you have. So you may train people, ask them to create a dashboard, and then forget about cleaning it up. And 2 or 3 years later down the road, you've done more training, and you end up with 10 or 20,000 dashboards that are never used. So those are the types of things that you may need to think about in terms of managing your metadata over long periods of time that, you know, this dust and cruft tends to sort of collect. Yeah, I think there's many other reasons why this can happen, but these were some of the ones that I wanted to highlight in terms of how these metadata issues actually arise over time. Actually, in version 40, and even in version 39, we had pieces of the back-end system in place. But thanks to our front-end colleagues, they implemented a new app or a new part of an app in the data administration module to allow you to basically utilize the metadata checks. So I'm going to give a demo here in a minute, but this is basically how it looks like. It's part of the data administration module. We've got the individual checks that are listed here, and then there's a lot more detail. We'll go through the demo in a minute, and hopefully it will make more sense. The metadata integrity checks, they always consist of a summary and then individual details. We wanted to give, let's say, an overview. We wanted to give system administrators an overview of what's going on. So instead of being able to be overwhelmed with so many different issues. You know, can we just give you a big overview in terms of what are the big problems in the system, or potential problems? So the summary really just consists of the number of problems, metadata objects that have been flagged, and we've also included an opinionated level of severity. And how do we determine, you know, what do we consider to be an error, critical, warning, and info? We made a best guess. Certain things, you know, from our experience of having done this for quite a number of years and in consultation with the development team, certain issues are a lot more important. For example, we have one check for organization units with trailing spaces. So these are spaces at the end of the name of the organization unit. We know in the past that sometimes people do this in order to distinguish between two different organization units that do have the same name. And in previous versions of DHIS2, it wasn't possible to have an organization unit with the same name. Now that's changed. You can have an organization unit with the same name. But in the past, people may have tried to distinguish this with trailing spaces. The problem with that is that when you get to analysis, it can become very confusing to know which one of these organization units am I dealing with, because I can't see the trailing spaces. Now, this is not a critical problem. It's not going to cause a system failure. It's not going to cause, you know, potentially your system to crash. So we tried to assign basically a severity to give you some idea in terms of what is the level of criticality of this issue as opposed to that issue. In addition to the summary, then we also provide a detailed listing of every single metadata object which corresponds to a particular problem, so that you can really drill in and see, okay, I found an organization unit with a trailing name. How am I going to fix this? There has been a best effort approach to link to the individual object, and I'll show how that works in the user interface. This doesn't always work, though, because it may not be the object in question that's the problem, right? You may need to fix something else in order to actually fix the problem. So we've tried to give you a way to get to the problem, but in many cases it may not be possible through the maintenance app to actually fix it. Yeah, I mentioned this extensibility through custom checks. I'm not going to go into the technical details of how to do this. It is documented for those of you that are interested or that want to pass this information on to your system administrators about how to create these custom checks. But in general, some examples that I came up with that may be specific to your instance, or you can really dream these up, right, for yourself, would be ensuring that all users have valid phone numbers. I know that in certain cases, a lot of system administrators are interested in being able to contact individual users. This might be to begin a WhatsApp group, Telegram group, send out SMS reminders. There can be many reasons why you might want to have a user's telephone number or an email address. We didn't feel that implementing those types of checks was possible for the core because it's not applicable to all DHIS2 instances. But for your particular instance, you may have certain rules that you want to enforce, basically. So can you create a check to say, okay, I've got 50 users that don't have an email address. I need to follow up with those users, figure out what their email address is, and then input it into the system. A lot of this work came out of the work that we did with PEPFAR on their DHIS2 instance, and specifically around the configuration of certain metadata objects and how they're related to each other. So in the PEPFAR instance, they had very specific ways about how users and user groups should be configured and users. So users should have a particular role, they should belong to particular groups, and so there was only a certain way of doing this, basically. Again, this was one way, this is nothing that we could implement in terms of a generic check because it's very specific to a specific DHIS2 instance. But through this extensibility, we wanted to give system administrators a way to basically implement it yourself using SQL. So you need to be able to have someone or yourself to write that query. They're not that difficult, and I'll give an example of one, but it's a lot easier than having to write Java and get it included in the core of DHIS2. So it does give you a way to extend the functionality of these metadata checks without having to get this necessarily integrated into the core of DHIS2. I already talked about the naming conventions. That's another kind of good example. If you have a specific way of naming your data elements or organization units, what have you, you could also create a check to check for all of the data elements that don't correspond to the your particular naming convention. Another example would be looking for facilities that don't have coordinates, right? Again, that wasn't a check that we could include in the generic DHIS2 software because we don't really know if all instances should have coordinates or not. But for your particular instance, you may have a policy in place to say, yeah, we need coordinates for all of our facilities, and we won't have a way to flag those that don't have them and follow up and get them. Yeah, demo time. Any questions before I move on to the demo? All right. So I'll just log in from, let's see, I was on this one. I just chose an instance here, and I did mention that this was available through the data administration. So we can go to data administration, and now this is part of the, I'll zoom in a bit here. So this is not a separate app, but it is part of the data administration module now. So obviously users are going to need access to that. This is not intended to be used by end users, right? Like say data entry staff. This subsystem is really meant for system administrators primarily, right? So that's why it was included as part of the data administration module, since it's really more intended for user administrators. This was what I showed you before. And all you have to do is come in here. All of the ones which we think are fast, and again, this is opinionated, but is based on sort of experimentation and experience. We wanted this to be very quick, right? We did not want you to have to wait for 20, 30, 40, 50 minutes to generate these checks, basically. So you can see I ran all of these, 60 or 70. I don't exactly know what the number is at the moment, but it ran almost instantaneously, or very quick anyway. And all of the ones that are checked with green basically means that nothing has been flagged, right? We didn't find anything that corresponds to a potential problem. This one, on the other hand, category option groups should have at least 2 members. Now, one of the things that we want to make clear in terms of this is that this will require some thought on your side to see if this actually is a problem, right? And in many cases, it may not be a problem, but we did want to flag potential issues. And so it may be quite okay to have a category option group with only 1 member. But part of the reason of using category option groups is to take multiple category options and group them together. So if you only have a category option group that has 1 member, it might be okay, but it might not be. So that's important to keep in mind, is that in many cases, this will require you to sort of triage the issue and determine, is it really an issue? It has been flagged, but it may not necessarily be an issue in all cases. And what do we mean by this? Yeah, so in this case, I think this is a good example, and you may not be able to see it. But I think the issue here is that this particular category option group only has 1 member, 0 to 1. And that may be totally okay, right? Because you may only have an age band 0 to 1. But in other cases, if you're looking at, say, less than 15 and over 15, you probably want to combine multiple age groups into 1. So that's kind of the point of this check. But I just wanted to point that out, that you do need to think about this a little bit, that we're not necessarily trying to say that everything that's up here is an error. It does require some thought. It will require you to think about, is this a problem in our instance or is it not? We'll scroll down and maybe find one. Aggregate data elements not in any data element group. And I can't get rid of that. Let's see if I can get rid of that. Show more. Make it a little bit smaller. We've also tried to include the severity that I mentioned. The section is kind of related to, like, is it a data element? Is it an organization unit? What are we dealing with? We describe what this check is about. And this basically says all data elements should be in a data element group. Why should all data elements be in a data element group? Yuri?
Dimension rather than each individual data element. I think it's
You did. I put him on the spot. Yeah, I mean, one like really key reason is in the data visualizer, right? When you select data elements, you select a data element group, and you want to filter by a data element. If you don't have a data element in a data element group, it can become very difficult to find it, right? So again, this isn't necessarily an error, right? This doesn't cause your system to crash or, you know, cause a problem per se. But, you know, Yuri pointed out some reasons about why you want to do it. There's also just a very straightforward reason for end users. If they're looking for, let's say, looking for general population, they go into the pivot table app, or sorry, the data visualizer app, and they can't find it because they look in the, you know, population data element group, but this data element doesn't show up. So these can also be usability issues, basically. We've also included recommendations in terms of how to solve this problem. Data elements that are not in a data element group should be added to a relevant data element group. If the data elements are not needed, they should be deleted. That's also a possibility. Yuri's got another comment, I'll take it in a moment. But it can also be, in many cases, again, coming back to experimentation, right? Maybe somebody's added a data element temporarily, but they didn't add it to a group, right? They just like, they add something, but it's not really part of anything. So it might also get flagged here, right? Yeah, Yuri, while I'm pulling up. Okay, sure. Yeah. Let me finish this and I'll come back to it at the end. Yeah, I'll try and answer it in a moment. I just wanted to show this kind of linking feature that we've included and say why it works sometimes and why it doesn't work in other cases. So what the front end guys did for us is that we linked to the maintenance app, you can see here. And then I go to the data element. The problem is I can't really fix this problem here, right? This is related to the data element, but the actual problem is its relationship to a data element group, right? So you'll see that sometimes this will work, sometimes it won't work. We'd love to hear feedback in terms of maybe how we can improve upon that feature. But for now, we've given a kind of best effort approach to link to the particular metadata object so that at least you can see what is this metadata object. You know, I need to flag it, I need to follow up and figure out what I need to do with it. But it doesn't necessarily mean that it's always going to work. For Yuri's question, they can't hear me? Ah. Yeah, Yuri's question was related to how do we delete data elements that, like in this particular case, let's say I've experimented with and maybe we can just do it, right? We'll add a new data element maybe. And we obviously, I just wanted to show how quick that we can do it. So if we add a new data element here, test data element. And I think we need domain type. Let's say aggregate. I think that might be enough, huh? Okay, now we go back to our data integrity check, and we're going to rerun this, I think. I thought I could run these. Yeah. I was going to say, I thought that we had done that. You can say that I ran all of the checks, but we also wanted to give you a way basically to run individual checks, right? A way to sort of look and say, can I rerun this particular check? And now you can see that this, it may not be completely obvious here. But you can see this is the one that I just added here. Test data element, right? So instead of having to run all of them at one time, it's also possible to simply say, okay, I'm going to focus on this particular problem. And I'm not going to worry about all my other problems, but I'm only going to focus on this. So then how do we deal with this problem? Well, we can go back to the maintenance module, and we can go to data element groups. And I don't know, let's just say that we put it in malaria treatment, and we find our test data element. And we hit save. And now we can go back to the data administration module and data integrity. And we can find data elements not in any data element groups. So we can find that one again. And we can only rerun this specific check. So we don't have to rerun everything. We're only focusing on this particular problem right now. And now we can see that that flag data element has now gone away, basically, right? So, yeah, I'll get to your question in a minute. So that's basically the workflow that we were thinking, right? Is that sometimes you can fix these manually through the user interface. In many cases, you're not going to be able to fix it through the user interface, and that's where part of where Yuri's question comes in. And Yuri asked, how do we get rid of a data element that has data? Right? Was that your question, Yuri? Yeah, so in certain cases, you may need to get rid of like a duplicative data element. Maybe someone has created a duplicate by mistake, and there's been data that's been entered into it, and you want to get rid of that. Yeah, we don't have like, unfortunately what I would like, the feature I'm dreaming up here is like a button that says fix this issue. We don't have that button right now, and we don't really have a direct solution for the problem that Yuri highlights is, you know, how can we fix it? How do we get rid of this data element? I do believe that the backend team has now developed a feature for merging data elements. So you can take an old, and let's say you have this data element and you want to merge it with another one, similar to organization units. So I think those types of features are in progress now to deduplicate metadata objects. Yeah, right now I think the only solution is that you're going to have to go into the backend database system and fix it yourself. Right, that's the solution right now. But we do want to improve on the tools that we have to help implementers and system administrators to solve these types of problems. There was a question in the back. Maybe we get a mic so that our online participants can also hear the question. Here, I'll just come to you.
Yeah, and which option, which version is available?
Yeah, so So this user interface is available only in version 41 and higher. We do have some solutions in lower versions, particularly version 40. There is an app that was developed by, don't look, I'm not going to admit to it. But there is a very basic app in the App Store for version 40. Don't laugh if you're a JavaScript developer. I did the best I could. But the front-end guys are a lot better at this stuff than I am. But for version 40, the back-end checks are there. So these checks are available through the API, and there is a really basic app that's available in the App Store. So if you're on version 40, you should be able to use that app. Version 39, there's very, very few of the checks that are included. So we didn't backport all of that to anything below 40. So yeah, 41 for the nice new shiny user interface from the front-end team. Version 40, there is in the DHIS2 App Hub. Let me see if I can find it. Metadata. Yeah, it's this metadata integrity app that should work on version 40. Yeah. Was there another question in the back? Not Yuri, but I thought I saw a hand. No. Okay, Yuri.
The reason I asked the question, and also since we were talking about the data element groups, I mean, you just generally want to keep your workspace organized, and having, let's say, a data element group for those elements that you want to delete or anything else can also help you gather that and then give them to the administrator and say, get rid of those from the database. So it's data element groups. We use them in the core team also to help us extract metadata and move it from one instance to the other. So it's just also the matter of organization of your daily work.
Yeah. I think we're out of time. I'm actually 2 minutes over. So I think we'll leave it there unless there's any last questions. Yeah, take the last question.
Up to now is fine, but the thing is you have said about custom integrated check. So do you want to show you later on?
Yeah, I'll show this really briefly. I will refer you to the documentation. Let's see. You can actually look in the source code, and of course displaying the source code on the screen is not great, but I did mention this YAML syntax, yet another markup language. And basically how you can do this for custom integrity checks is you need to follow this pattern. So if you go into and you read the documentation, you go and see, you know, we need a name, we need a description, a section, a summary SQL, details SQL. So basically all of these things need to be done exactly as we have done it in the core. The SQL query needs to be written in a certain way, it needs to return data in a certain way, but we have documented how to do this. I think it's pretty straightforward, really, particularly if you're comfortable writing SQL queries for DHIS2. This isn't really particularly complicated. And then those can be, they need to be put in a particular directory in your DHIS2 home, and you restart your server and they will become available via the user interface, basically. But I'll leave the details to the documentation. If you want to talk one-on-one about maybe experimenting with your database and you have some ideas for your custom checks, I can also help out while we're here. And please, if any of you, once you get a chance to check this out and have a look, if you guys have ideas for new checks, things that we're missing, we've got a lot of suggestions from implementers in the field, DHIS2 administrators that have been working with DHIS2, things that we haven't thought about. We can always try and include those into the core checks. So please feel free to feed back to me. You can find me at jason@dhis2.org, If you have ideas for new integrity checks, or in certain cases, people have found bugs in the ones that we have implemented. If you're checking your database and it doesn't work the way that you think, then please feel free to feed back to us, since all of this is relatively new. Great. I think we're out of time. Actually, a few minutes over, but I'll turn the floor back over. Thank you.
Okay. Thank you so much, Jason, and to Nick, who's presenting in another room right now. So we will have our tea break now. So our tea break will be 30 minutes. So we will start our next session at around 3:30. So in this room, the session will be about integration. So if you want to go to the session on visualization tools, please go to another room after your break. So yeah, you can take your break now. room, we're going to talk about integration, and we actually have 4 presenters for you in this session. So we're going to start with talking about the Client Health Registry as it's implemented in Lao. And I'll ask Sam in a moment to come up here and present that for us. Then we'll have Yuri from the UIO team present on CRBS integration in Uzbekistan. After that, we'll have Jason come up here, and he's going to talk about a data exchange application that he's been working on quite a bit lately. And then we'll have Bjorn and Ev finish off the session discussing the regional TV migrant system that's been implemented in Greater Mekong Subdivision. So I'm going to ask Sam to come up first to start us off with the Client Health Registry.
And thank you, Nick, and good afternoon, everyone. So I will start with the Client Health Registry. We talked about this yesterday and also a little bit this morning. Then I will have this opportunity to go a bit deeper to what it really is and how we are using it in Laos. Okay, so I will start with what is the Client Health Registry in our view. So the Client Health Registry for Laos is just the database of the persons and the key demographics of the person who receive public health services in Laos. But this Client Health Registry is not just only the database for that, it also will issue the Client Health ID that will be used for many health programs in Laos. So, but the Client Health Registry is not only for Lao citizens, because in other countries we have CRBS. So CRBS in Laos is also focusing mainly for Lao citizens. But Client Health Registry is more than that. And we see in the when we were doing COVID, where we gave vaccines to foreigners as well. And this Client Health Registry is kind of the same. So foreigners or non-Lao citizens also will have the ID and can receive health service in Laos. And the last one, also important, this is the point that why we need to use Client Health Registry in Laos, because there are many health programs starting to enter data as individual. There are many hospital management information system as well, and there are many other software that are tracking clients, but there's no linkage between those systems, so we need to have this. And for Laos, since we are using this tool for many health programs, we already have the database from the COVID, so we utilize that and made it as the Client Health Registry for Laos. Just a bit on the data in the Client Health Registry. So as I mentioned, the Client Health Registry is just a database where you collect or store information of the clients, and there are basic details about the client. So first name, last name, date of birth, other ID like passport or citizen ID. They have also blood group, ethnicity, racial status, occupation, and education. Going back to the first slide, so for Laos, the Client Health Registry will be used as the integration link for many health programs. So basically, instead of each program talking to each other, we need to talk to just Client Health Registry, and then all the software that we try to use or to access to client health data, so we can connect to CHR. So I talk a little bit about health programs. travel to neighboring countries where they have higher standard of healthcare service. People usually cross the border to get the service in the neighboring countries, and that's very difficult for Lao to have this data. And there are so many percentage that people having service at the facility we cannot capture. But through the linkage with PCRDS, we see that even though you get the service from somewhere else or from private hospital or from anywhere outside the country or outside the public facility, at the end of the day, they will still need to go to the Ministry of Home Affairs to serve or get certificate or the registration. And that way, for health, for data that we cannot capture in the health system, from this university, we can get the data from that system, and that will be beneficial for a program like the EAR. For example, the birth may happen at the private facilities or outside facilities. When they do the registration at MOHA, we can get that information that the health program, especially EAR, can follow that child to make sure that the child that deliver outside of countries or from somewhere else get the right or the correct vaccines. So this is what we are currently doing right now. To simplify one, is just when the birth happen, we also send data to ECRBS. So when the birth register in our system, we send over to them. They will be the one to check, to verify. When they issue the birth certificate, they will confirm and give us the citizen ID to help, and that we can continue with the rest. And I will not go into the detail, but you can have the slide on the technical side. And same thing for BAMI, for integration. In Laos, there are many hospitals are adopting the hospital information system, and many of them are using BAMI right now. And there is a need that anyway people can visit any facility, their data can be captured through this system, but at the end of the day, it will be linked to DHIS2. And for BAMI as well, because they need to have the same ID. And before they can enroll the patient into their system, they need to talk to our CHR first to see if the person is already enrolled. And if that person already enrolled, then they can just retrieve that information with the ID and continue the treatment. Or if the new patient, they can inform DHIS2 about the new patient and then get the CHID and continue with the treatment. So that's basically with what we are doing right now with CHR. And the CHR right now is only for the health side, and within the health, for the health worker, for the hospitals. Another possibility, we are thinking like what we did with COVID, where we have the people need to have this proof of vaccination, right? When they travel, they need to show this. And the same thing can be done now because we have the CHR, the citizen can get their own data and also retrieve all the history that they need. Maybe we can start with the immunization. That's now will be the requirement, right? Before the child can get to school, you need to show that you get all the required vaccines. And to have that information, at the moment you just need to have your book and then visit facilities to certify. But with this app, you already have your data in the database. You can just retrieve with to retrieve your information using your credential, and that's something we can do with the CHR, and that's the plan that we would need to do in the future. And that's all for the CHR. So I'm not sure you would like to have one order presentation and then question, or can do the question now.
So I think we'll have one more presentation before we open it up for questions. So I'll ask
Thank you so much.
Big round of applause for Sam. So if I can ask Yuri to come up, and he'll share with you some information.
notes, or is that possible? I can't do presenter notes, right? Because you have only one screen. I could maybe get my. Sorry for the delay. Okay, hello everyone. Nice to be here, nice to be presenting here. I'll quickly explain why I'm standing on this stage. Last year in Sri Lanka, I was presenting the use case in Uzbekistan, and on behalf of the MOH and the NTP program, we were talking about the implementation that we started in Central Asia. And yeah, so I hope you were wondering how it went. And we have launched a TB electronic registry implementation in Uzbekistan this summer. A country with 35 million people and a lot of cases of TB. And this implementation led to something that I'm going to share with you today, which we call the DHIS2 Civil Registry Lookup. So, and I will also explain how a use case turned this into something that can be global good. So, Uzbekistan has started an electronic TB registry, which is a very complex program that already incorporates and will incorporate several modules, beginning from the registry itself, the laboratory module, the screening and the contact tracing module, then surveillance reporting, medical statistics reporting, a plan to transition from paper forms to electronic forms, and then the integration with the national medical information system. You can see that from the images that I've put, that apart from a country being very advanced IT-wise, there's also very low coverage and very low literacy digitally on the level of districts and regions. And so there's a lot of capacity, but it needs to be organized. It needs to be rearranged. Also, sometimes the mentality within the organizations and government has to change in order for innovations to work. So, what was the use case here? We have in the tracker system itself, when registering a TB case, and I've just put a screenshot from the DHIS2, we have 18 data points for each case. And I think within the first week of the implementation, they registered 3,000 cases. We are dealing with a lot of data that has to be entered into the system. Some of it, most likely just for, I would say, bureaucratic purposes, but that's something that the country needs. But at the same time, as we have that demand, we have very low digital literacy skills among the personnel in districts and regions. You know this probably from your countries. These are people that are close to retirement age. They're working in these facilities, entering data, and sometimes they are working in several data entry systems, starting from paper, Excel, then an example of this in this screenshot is an old MS-DOS, totally isolated from internet, that they call digital. And we want to bring it all together into one unified tracker. So then we have a lot of duplications and inconsistent data. We have 2 alphabets used in the countries, so that creates a big mess. So we had to find a solution to support the country in finding some way forward with that. On the other hand, the government and the ministries that advance much more rapidly with digitalization, they require integration with national systems. They require data exchange between the programs. And so part of their requirement for a platform like DHIS2 to become a nationally owned system is the fact that it needs to be integrated. And so we had the request to set up a civil registry integration. And that's when we started to think of the principles of, what partially what Ulla was sharing yesterday, is that how we can do that, how we can turn that into something that can be a public good. So what was needed to be done? We had to automatically fill in the demographic information from existing civil registry when registering a new tracked entity in the Capture app, okay? And optionally correct the data that was previously entered, which might have been incorrect. Is this the first time it has been done? No. There have been several cases where such integrations were built. One of the latest one was Norway during the COVID time, where the integration with the civil registry has been set up. But all that required some complex tweaking of the code and sometimes forking the system. So with the new developments and updates in the DHIS2, more things became available and easier achievable. So what was the goal of the core team at UIO to achieve with this? So we wanted to avoid forking DHIS2 and Capture app. We wanted to support the adaptation to different civil registries or any DHIS2 metadata. And we wanted to provide strong security and privacy guarantees using those DHIS2 features, and then allow straightforward development of custom solutions. What was the solution that we came up with? It was to develop a reference implementation which can be used and adapted by any country, by any organization, following the best practices and using native DHIS2 features. So this reference implementation is already fully functional. It's self-contained example of a DHIS2 instance integrated with a civil registry. And in addition to serving as an example, it can be adapted and modified for use. So what does it consist of? I'll go in a few details, just enough for you to get an idea of what it is. So with the newly available plugins in the DHIS2, we have made a form field plugin in Capture app. And if you were attentive, you would have seen in the screenshot there was a search button next to an attribute in Capture. And then we have an API route that communicates with the upstream services. And the team has built a middleware component, a camel middleware, with customizable transformation and authorization support. And this is something that you might want, or an implementation might want to adapt, depending on what registry or what platform you want to integrate with. And since it's a reference implementation, there are a few additional components were added. So an example upstream civil registry was created, and an Auth2 authentication service. So these were to demonstrate the solution, but in a real implementation in a real country, this would already exist or already be present. So you will just need the plugin and the middleware to adapt. Here is the flow or the flow chart of this plugin. So here we have a civil registry where the payload will be exchanged using, as an example, FHIR standards. And on the other side, you have the DHIS2 and the plugin in the Capture app in the browser communicating with the middleware, and then through authentication, receiving the data and putting it back into the browser. Why this middleware has been set up? It's because the thousands of users that you have in your system, they do not necessarily have access to the civil registry. So that middleware handles the transaction and is always in the authenticated state. And only admins of the system have access to configuring that middleware. And so to make sure that the users, by searching in the civil registry, may get the information at any time without having direct access to the civil registry itself. So, and this configuration is available in GitHub, and with clear instructions on how to test it. So you could set it up locally to try, and then you could see whether you need it in your implementations. That definitely will, of course, require tracker and integration with registries if needed. So I think that was it from me. Here is just an example of that it's live. As you can see, here we have the Capture app, and by putting the ID, we're searching for it, and instantly we get the data filled in for our case in the app. So with this, thank you, and I'll pass it over to you.
Yeah, thank you very much, Yuri. So just before we move on to the next presentation, are there any questions for our first two presenters, either Yuri on the Uzbekistan use case or Sam on the client health register? Yes.
Thank you for a nice presentation. Two questions actually. First thing is Auth2 authentication. So is it the Auth2 authentication required for the CRVS or our side, means the DHIS2 middleware size? And second thing is why need FHIR to be communicate with the CRVS? Because most of the country has the CRVS system, might not have the FHIR built in because it's not the health system. Mm-hmm. So why don't you use the REST and other protocols?
Okay, I will start with the second question, and as little as technical I am, I will just say that I mentioned FHIR because the use case of Uzbekistan, it was a FHIR-based civil registry. But the idea of that mock-up reference implementation is to be able to link to any. It does not have to be FHIR. So you just, the middleware would be used as a translation tool, and whatever parameters you would have there, that you'll be able to set it up. And Auth2 authentication, I think that's, I would be skeptical taking that question now, but I guess it's on the side of the DHIS2, yes. No, on the. Okay, John.
Okay, So on the auth2, it's usually on the other side, because like even with our other registration, we have to, they will give one username, right? In DHIS2, like what we have multiple users, different hospitals are searching by their user. So the middleware, what we takes around is the DHIS2 connector and with their authentication. It's not the DHIS2 user, but it's the account what they give it to us.
That's fine. That is normal, because besides authentication, you have to produce or give them a key for the whitelisting. But my question was whether that need to be auth2 or any type of authentication. Because if you were constrained to auth2, that will be very dangerous, because that system might not have, because we don't have control over the national CRVS system.
Okay, I think the answer here is very clear, and in the diagram it showed that the auth2 service is a part that was added to the reference implementation as an example. But if you have a component that's not auth2, then you will just need the plugin and the middleware for it.
Thanks. Any other questions for Yuri or Sam? Yes, on the back.
Yeah, so question on what I have seen as a demo. Have you had any challenges trying to address like getting the consent from the personal record owner? Because I saw the automation happening, but were there any concerns on getting the consent first before the authentication happens, or is it not an issue in that implementation?
But are you talking about the consent from the
person itself? Yeah.
No, I think that is not the case that is managed by this plugin, because let's say this is a TB implementation, so they would be registering the cases in any way, whether it's an Excel or any other data, and the data on these people is already present in the civil registry. So at this stage, there's no consent given there. But from what I know in reality is that once the people are registered, let's say in a TB registry, and then if they don't want to appear in any kind of statistics as individual, they can remove that consent, and then the data will be anonymized. But that is a different, that's a use case that you will have to govern within your implementation, not within this.
Presently, the DHIS2 cannot be connected with the CVRS. This is not a case-based. The DHIS2 is working actually on the aggregated data, and CVRS is totally a case-based. Like when a birth or a death occurs, there will be a registration, if I'm correct.
I think we're talking about different registries, because in my example with Uzbekistan, we're talking about the database from the Ministry of Interior, where every citizen has a national ID, and so that will just fetch their data into DHIS2, and we're talking about tracker. We're talking about case-based data. Yes.
Yeah, for tracker.
Yes, yes.
Yeah, thank you. Thank you, Yuri. Just a quick question on the OTP. Did you use Google Authenticator or the SMS, the OTP? Have you used for the credential authentication, I mean?
No.
Yeah.
So they have, specifically in Uzbekistan, they're using single sign-on, and the...
single sign-on,
yes,
okay.
Yes, yes.
Thank you.
Okay, thank you. I know there are some outstanding questions, but I think we'll move on to the next session, and we'll have some more time for questions at the end of the session. Okay, so I'll ask Jason to go ahead and walk us through the data exchange app.
Test, test. Can you hear me? All right, looks like it. Okay. Let me get rid of this here if I can. Okay, I'm back on stage. This time talking about the aggregate data exchange service and app. This is a relatively new feature. I think it's been around for a while, though. It's not completely new. We've made a lot of updates recently, both to the backend service, thanks to our colleagues from DHIS Vietnam, as well as to the front-end app produced by the Oslo development team. I've been working specifically over the past year or so with the Global Fund, who is implementing their own version of DHIS2, their own instance basically, to facilitate collection of data from the countries that they work with. This was a big initiative on their part. Previously, they collected a lot of data via Excel and wanted basically to try and streamline a lot of this collection that they need to collect from their countries. There was already a sort of pilot initiative that the Global Fund had used to collect data specifically on COVID during that time, and has now been expanded to basically the whole portfolio of Global Fund indicators. I know that a number of other countries, I think Pakistan also is using the aggregate data exchange, right? So I know that there are some other uses of this, but we wanted to go through briefly. I've got, what, half an hour, John? Something like that. 20 minutes. All right, so I'll have to go quick. To show you both, what can this do and basically how to use it. So, yeah, there's a new backend service and app in 239 and above. It allows the transfer of aggregate data between a source instance and a target instance. And this target instance can be the same instance, actually. It can either be a remote DHIS2 instance, another DHIS2 instance that's located somewhere else. There can also be an internal exchange, and I'll explain the differences between those two. The exchanges can be scheduled, so you can automatically run this like every day, for instance. You can trigger it via the API, maybe if you're using like an external script, for instance, or performed by a user using the new data exchange app. So here are some example use cases. This is certainly not exhaustive, and I suspect that people are probably going to come up with things that we didn't think about. But one of the primary use cases is the transfer of data from, say, a national HMIS instance to a regional data warehouse. So you might think about exchanging data between your national HMIS and the WHO Global Malaria Program, or the Global Fund, for instance. So instead of having to fill out some Excel sheet or log onto their instance to re-enter the data, it would be a lot easier if you can just, get the data right out of your HMIS and send it onwards to their DHIS2 instance. Another very common use case is the transfer of tracker to aggregate. So going from event-based data to aggregate data. And one of the primary reasons for doing that, it could be because your tracker data and your aggregate data bases are separate. In many cases, you may want to keep the tracker-based system completely separated from your aggregate instance, either for security reasons or other reasons. In certain cases, they may be all integrated together. In other cases, they may be completely separate. So it would facilitate the transfer of the aggregated event tracker-based type of analytics to your national HMIS. It could also be the internal transfer of data from event-based data to aggregate data. And so why would you want to do that? Well, typically it's because of performance reasons. So if you're looking at aggregated data that's already been processed, then it's typically orders of magnitude faster than having to go from the event-based data and aggregating that in real time and then displaying it on the dashboard. So if you can pre-aggregate all of that and sort of push it in aggregate format, that may serve the needs of users that only need to have access to the aggregated data. Yeah, this is another one I think that we've seen as well, the aggregation of data from facility level to a national level portal. So you might want to have a portal that is open to the public, for instance, but you don't want to necessarily expose facility level data. So you might want to aggregate the data from facility level to something higher and give that to a broader audience of people, basically. So those are some of the use cases. It's definitely not exhaustive, but those are the ones that came to mind. Anybody else that's maybe using the data exchange might have another use case? Yeah, Hanan?
Okay.
No. She could have used my mic, I guess. Yeah, that one's hot.
Thank you. We have a use case where we're using for urban health data. So we are implementing an urban health system from last year. So the idea is this is a case-based system. So this is a tracker which actually collecting data on the all service provided at the facility level. So the facility, the service provider, they enter in the data. This actually aggregated and send it to the for the annual development plan and Asian Development Bank reporting. So they are an aggregated template. So we actually put the data every month so they can review and say it's approved. And after that is actually using the ADX, aggregated actions, to the aggregate data set from where we publish those two specific reports. So this is ADB report is a 65-page report, pre-formatted report. So that's we make on portal. So from that we send to the portal as well.
Yeah.
So that is our use case we are using. And I think this is a good example because this is a cross-checking. So it's creating data, aggregate data from the case-based system. So there is no manipulation possible. So this is a good, for our case, it's a good improvement in the data quality as well.
Great. Thanks, Anand. So that's sort of what aggregate data exchange can do. In terms of specific features, any aggregate data could be exchanged, all right? We're talking about aggregate data. We're not talking about tracker or events. It's strictly aggregate data here. It can be data elements. It can be indicators. It can also be program indicators. So basically, any of these types of metadata objects that can produce aggregated data can be exchanged. It's very important to point out that data can only be pushed, okay? Cannot be pulled. So this was a very conscious design decision, right? What we did not want to implement was sort of give, a global organization keys to your system. So this allows you to decide when you're going to push the data. It doesn't say that, if you're working with a global fund or the ADB or WHO or whoever it might be, PEPFAR, they can't go into your system and pull it out. It only allows you to push the data into another external system when you choose, basically. Yeah, I mentioned this. Data can be exchanged at any level of the hierarchy. It could be at the facility level, but for instance, I don't know, in the case of ADB, perhaps you're only sending them, subnational 1 level data or national level data, as opposed to individual facility level data. Again, that's up for you to configure, and I can show that in a minute. Data can be exchanged for either relative or fixed periods. It can also be for aggregated periods. So like in the case that Hanan pointed out, when you're collecting data by in events or tracker, that's collected on a daily basis, but perhaps you only want to share, maybe you need to give a quarterly report. So you're not going to give that data by day, and you could aggregate that data and push it to the ADB in quarterly format, but for your own instance, you might want to have a daily aggregate summary, right? So Depending on what the exact use case is, you could use either fixed periods. Normally, relative periods make sense. You know, last 12 months, last 52 weeks, last 10 days, something like that. Because then you can regularly sync the data over time. It's also possible to use fixed periods, but relative periods normally are better. You can use a filter. A common example for this might be if you're, I don't know, I'm just dreaming something up here. But let's say that you're working with a global donor that's supporting a subset of your facilities. So they're only working, you have to provide them a report, but it's only these facilities that they need a report from. You can use a filter, an organization unit group to say, okay, we're going to send facility level data, but we're only going to send this particular group of organization units. So you can apply basically any type of filter to the request. There are also support for multiple coding schemes. And this is a little bit difficult to understand, but you can think of it if you're, let's say, having to exchange data with both WHO as well as the ADB, they might have different coding schemes, right? For the same data element, number of cases of malaria, for instance. WHO might have a coding scheme that says this is the code for this data element, and ADB might have a coding scheme to say this is their code for the data element. It's the same in your system, but you could apply a different code depending on who you're having to send the data to, essentially. So how does this actually happen? There are basically 3 properties that you need to set on the metadata object that you want to exchange. And by metadata object, I mean data element, indicator, or program indicator. And you may have noticed this in your version of DHIS2. There are 2 new properties that are available on these metadata objects called category option combination for data exchange and attribute option combo for data exchange. The third thing that you need as well is the data element, right? And that's normally used, that can be configured using an attribute. It's also possible to use an attribute for, these are data element UIDs, and this is a attribute option combo UID. But again, given the flexibility of the coding, you can use an attribute basically to support multiple types of coding schemes, depending on exactly what your use case is. But if you've noticed this in the maintenance UI for data elements and indicators, the reason is because of aggregate data exchange. So all of this needs to be configured up front. You need to know what the code is on the destination system. It might be the UID. It could also be a code. And that needs to be configured in your instance. Now for internal data exchanges, it's basically the same thing as well. Because remember, for an internal data exchange, you might want to calculate a program indicator that represents a particular data element category option combination. So you might have number of cases of malaria, less than 5 female, right? That would be a particular, that would be one program indicator. And that would map to one data element category option combination. And that would need to be configured in the program indicator for number of cases of malaria, male less than 5. It would be a different category option combination, but the same data element. So you would need to configure all of that mapping basically up front. So this is what the UI looks like. I'll show it in demo form. It's not really super clear on the screen. I hope it's better via Zoom. Data exchanges can consist of multiple requests. So you can organize basically one exchange, and then you can have multiple requests within the exchange. The exchange can either be internal or external. External refers to a remote server. Internal refers to within your own system, basically. External exchanges can be used with either a username or a DHIS2 token. We recommend for security purposes that you use a token as opposed to a username and password. And each request can have a single input coding scheme. Input coding scheme refers to what is happening on the target server. So how should the target server interpret all of the codes or UIDs that you're sending to it? Now, each exchange can consist of multiple requests. And any request can be filtered on any dimension. I mentioned this, that it could be filtered by organization unit group. You might only want to include a subset of facilities, for instance. It's possible to link to a visualization, and the reason that you might want to do that is to allow people to look at the data, the aggregated data, whatever you're going to send in the data visualization app prior to actually sending it. Data items, and I put this in quotes, these, as I mentioned, can consist of any combination of data elements, indicators, or program indicators. Periods can be fixed or relative. Yeah, and I mentioned this support for multiple output coding schemes. And output coding schemes refers to the coding scheme that's going to be produced and then sent onwards to the external server, basically. So you might want a request that uses codes. You might run a request that uses UIDs, and all of that needs to be configured as part of the request. This coding scheme stuff gets a little bit tricky and hard to understand. We've tried to, the best way I think is maybe with trial and error, but I did want to try and maybe explain what this means. Output refers to the coding scheme which the aggregate data request will produce, okay? So if you've maybe seen this in the data visualizer, you can export data either with a UID, with a code, or with a name. And the aggregate data exchange service is using the exact same analytics service, basically. So you can say, output this request with a UID, output this request with a code, output this request with an attribute. So that's basically what this means, is how are we going to output the organization unit? Should it be a code or should it be a UID? Well, the input refers to what the remote server is going to interpret that as. Is it a code or is it a UID, right? So the terminology is a little bit confusing, but I think if you play around with it, it will make a lot more sense. This is what the app looks like. Again, the resolution is not great here. It's not installed by default, but it is available on the App Hub. You can just go to the DHIS2 App Hub and search for Data Exchange, and you can download and install the app. It does allow the user to preview the data, and that might be important, particularly if you're sending a report to the ADB. You might want to take a look at what you're sending them. Maybe, you might not. But that's what the app is for, is to allow users to look at the data prior to sending it to be sure that it looks okay. I wanted to include some limitations that we found thus far. Very large requests may time out. And what is large? That's hard to say, right? It depends on a lot of factors. I'm just going to say large can mean many data elements. It can mean many data items. It can really depend. But what we have seen is that very large requests may take too long, particularly if you're using the app. What will happen in the app is after a certain amount of time, then the server will time out, right? The reverse proxy server will time out, and you'll get an error in the browser. Now, if you're using the scheduler, this may not happen because everything is happening through the back end, but it can be smart to test this out and make things small, basically. Things that will complete within, say, 10 minutes. If it takes longer than that, then it's probably not going to work, and you're going to have to use the scheduler in order to actually perform that. One major limitation is there's no easy way to delete data that you need to delete. And a very common, I think we talked about this, I heard about this from Pakistan, is that what can happen, particularly with case-based data, is let's say you've got a case on today, but then a case of TB, right? Somebody comes in, they're diagnosed with TB, but they're recorded as having yellow fever, right? They're misdiagnosed. What happens is you perform the data exchange, and then it gets into the aggregate data, and the disease surveillance officer says, uh-oh, we got a case of yellow fever, and all sorts of alarm bells go off, and somebody's got to go back, follow this up, and says, oh, no, we just made a data entry error, and they correct the diagnosis to TB instead of yellow fever. The problem is, and you want to perform the aggregate data exchange again, but that data is like null. It doesn't exist, right? So there's no way to delete that data easily on, and I say easily, there's always a way to delete it, but there's not an automatic way to do it, right? So you may have to flush the data, you may have to go in and manually delete it, but there's no easy way to kind of transmit that the data needs to be deleted on the remote instance. Yeah, I put this as a limitation, but again, data cannot be pulled. This is by design. There have been some people that have asked for this, but it's specifically designed not to be able to pull data. But it is a limitation. You might have an instance, particularly if you're working internally, you might be able, you want to pull data from, say, you have a tracker instance and you want to pull that into your aggregate system. There's no way to do that. It has to be pushed. There's limited authentication options right now. Only username and password, and the DHIS2 token is supported. Hopefully that will be expanded, but that is a definite limitation. This token expires after a certain amount of time. Using usernames and passwords is maybe not super secure, so that can also be in a limitation. Yeah, and again, currently only aggregate is supported, so you can't push events, you can't push tracker data. And I see I'm up for time, just in time for the demo. I'll just give a really quick demo here. I'm using using one of the Global Fund systems here, and this basically represents the Global Fund side. Okay. And you can see that there's no data here for June 2024 for Vanuatu. But this is representing the countryside. So let's say that I'm in Vanuatu and this is what my system is, and I want to push data to the Global Fund. I can choose this, and I should get a preview of my data. So this allows you to see all of the data that you have configured, basically. I'll just show you the configuration really quickly. Most of this stuff is documented. We specify that this is the target, uat.8x.theglobalfund.org. And we've got a request here. And we've specified these 1, 2, 3, 4 indicators. All this is fake data. Not real, for the last 12 months for Sierra Leone. So we're saying, I just changed this, I changed the code from Sierra Leone to Vanuatu just so that we can see this. But you can see the point of this is that we've now aggregated the data to the national level. So the only thing that we're going to send to the Global Fund is national level data. We don't send them the disaggregated facility level data. And then we specify the various coding schemes here. This is, we're using a coding scheme called an attribute Global Fund data element ID. And the organization unit ID is code. And in this case, just the ISO 3 code for Vanuatu. Okay, so I can cancel all of that. We go back here, edit, let's see, choose this. Need to exit configuration mode. Go back to the demo. And the moment of truth here, we'll say submitting data. And then I say 60 imported, 0 updated, 0 ignored. So that's good. That means that 60 values were transmitted from the country instance to the remote instance. Now if we go back to what represents the Global Fund system, and we check for May 2024, then we see data for there. We go back to June 2024 when there was no data. Then we should see 428 for CM1A, and if we go back here, let's see, did we get the right number? 428 right there. So CM1A, June 2024 is 428 on the national system representing Vanuatu. And in the remote system, we see the exact same number in the data entry app. So that's basically how it works. There's more documentation out there. We've got a couple of deeper dive presentations that we could provide you with as well. We conducted a academy in Addis a couple of months back. That's it. I hope it gave you a good overview. I don't know if we have time for questions, but thank you very much for your attention.
Thanks, Jason. Yeah, so we'll take some questions at the end. I'll just ask Jorn and Em if they can come up now and proceed with our final presentation for the session on the TB migrant system.
Ska du ha micken?
I'm not like Mick Jagger, you know. Where do I change? Just this one. Okay, good. Yes, this is working. I can hear it myself. So we are presenting is myself and Em also. We share it. I start, and he will continue on the last part of it. This is about the regional database. Region meaning the 5 Mekong region countries like Vietnam, Myanmar, Thailand, Laos, and Cambodia. And basis for this referral system and regional TB database is a general DHIS2 TB database following WHO standard and so-called package, but it's including a specific referral module, meaning that there's a lot of features that are specially designed for enable referrals between countries. And central is the so-called TB09, which is a relatively standardized referral format. And what has been done is that we have different languages in different countries, so data variables have been identified, translated, org unit hierarchy from TB units, province, not districts, and country are both translated and included from all these countries. User roles created, and important, a general SOP is created and specific for the pilots between Cambodia and Vietnam. So the motivation for having a specific focus on migrant is that migrant TB patients, they are kind of ignored and they are kind of suffering from a lot of problems, and they are easily missed out of the TB systems, lost to follow-up when they are crossing borders or just moving around. So the project is kind of addressing the TB, the TB in migrants and trying them to ensure that they are followed up and to generally focus on TB in migrants. And one of the general problems with TB and migrants is that countries are generally not so very inclined to include them in their systems and databases, etc., because they are all reporting cure rates to WHO. And since migrants are kind of on the move and tend to miss out, that's kind of always impacting on the cure rate of the countries, and they don't like it. So that's a reason why many are kind of not so very focused on including migrants in their different schemes and databases. Of course, the countries in this project, the 5 countries, they have agreed to never do anything harmful against migrants and include them in the databases, etc. While in practice it's easily missed out. And that is kind of the motivation and for this TB database, migrant TB database project. So all the Mekong countries, they have included foreigners, which is the definition of migrants. It's a simple definition. They are all include them in their national databases, but they are kind of categorized differently. Some are just not categorized at all, like at least earlier in Vietnam, they couldn't really identify foreigners, whereas others have so and so many nationalities that are kind of using as categories. This is, of course, a slight problem when it comes to statistics, etc., and to follow up of migrants on a kind of a higher level. And it's worth to note that many countries not in this region are simply expelling foreigners that are testing positive for TB. For example, Malaysia. That's the first plane out if you're testing. And that's, of course, that stigma is the reason for many of these problems with TB in migrants. And these are the countries that are part of the project. Of course, Myanmar is not really active in this because of the war and problems, and there are not really any contacts with the official health system and Minister of Health there, apart from NGOs along the border. And these are how it's actually working in practice. It's a referral of TB patients between countries. This is a typical example between Thailand and Lao PDR. They are having point-to-point transfers between what they call twin hospitals. And they're using different methods. They have their own kind of setups, and there's no systematic approach, and they're using Line or WhatsApp to send messages, and they have telephone calls, and it's one referral, online referral system we identified. And these are who made that are located in Chiang Rai province, and we have actually worked with them after that. We kind of identified them as the only kind of systematic way to do referrals. And again, if you look at the Myanmar border to Thailand, there the referrals are kind of physically carried out by an NGO, which are kind of following the patients over to the other side and using a paper-based system. And what is important when it comes to TB general is that, first this one, then just an overview. We have started a pilot between Vietnam and Cambodia, and Em will tell about that. And we are testing referrals between Thailand and Lao PDR, and they have agreed to start a pilot once we have these things organized. And the challenges generally is that every time you try to deal with data between two countries, then they will come up with data sharing agreements. And that is raised as a concern also here, of course. What we are saying is that patients are actually referred in any cases, so I mean, whether it's a data sharing agreement or not, data and patients need to be kind of transferred across the border. So that is kind of the general approach to that. And another problem is that there are different standards for these so-called standardized TB09 referral forms. And that's also true, and we have some approaches to that also, and that is to be a bit pragmatic and use what is at hand in the country that is referring out the patients. And what is also quite a big challenge is that all the countries in the region have different scripts and languages. These are then Bangkok written in the 5 different languages, but more importantly than the scripts between the countries. And you see that the problem is that, of course, when you do referrals of patients, then you fill in forms, etc. But the patients who are going, say, from Vietnam to Cambodia will not necessarily be able to spell the name neither in Vietnamese nor English. And that is a kind of a problem in the general referrals of patients across the borders in this region. This is the kind of the age-old workflow. I think it's emanating from the WHO long back. I heard the story once. And that is kind of, you send the referrals consist of a form where you have the patient demographics, you have the treatment and the diagnosis. That's one part. And then you have 2 other parts, which is the feedback. One is that you have a receipt of the referrals when the patient is arriving on the other side, and then you have the treatment outcome. And the treatment outcome is what is kind of messing up all the cure rates in countries, and the general reason why they are not so interested in handling foreigners in referring out of countries. And we have put up this is then the kind of the standard operation procedure and how this is translated into the regional database. And we see that there's a lot of reply messages for these feedback messages. Patient is received, this is the outcome, and these messages are then going both to the referring unit and also to the national TB department. And you see here that we have the country TB database in each countries, but there are different ways these TB databases are included in the setup, because some countries require that referrals must go from the national database to the national database. That was the start of the work in Thailand, for example. They required that it had to go from their database. Whereas, for example, as I mentioned, others of different reasons prefer to actually be a point-to-point referrals across the borders with as little as possible interference with the national databases. So we have then kind of a number of different scenarios which are possible, from automatic kind of referrals from national to national databases via the regional database, and where one side can send from the database and the other can just download as Excel and print out. So there are many varieties that are possible. And what we are testing out in between Cambodia and Vietnam, that is actually point-to-point referrals between the 2 parties using the online systems. Whereas what we try to do in Laos and Thailand is then to send more automatically from Laos side and to receive it or download it as a Excel in Thailand and upload to their system by that. So this is what we are about to test out. And of course, we have this. We have the example of Myanmar also, where, say, Thailand will say send it electronically, but then you will download or print, and the patient and the NGOs will carry it over to the other side. But what actually was tested with this first example I mentioned is that you have a person with online access on the Myanmar side. That's also possible, and it's been some efforts to achieve that also. So this, what we can call a pragmatic approach to address the different challenges. For example, the requirements from Thailand is that we don't want any interference, direct contact from a non-national software with our national software. That's why we came up and said that, okay, but then let's do it semi-automatic via Excel. You can download Excel and upload Excel. Then it's okay. Then there's no direct link between the two. And another obstacle was that but all countries have different TB09 standards. And then we are saying that we cannot wait for agreed standards because we know that standardization is something that will take forever. So the suggestion is for each of these kind of twin systems, and the referring out country standard will be used as a rule, as a start, and then if the receiving country want to have other data in addition, then okay, then they can request that. And if they actually needing less, which is as often, then it's not a problem. So then we have this other general problem of no data sharing agreements. And then we are saying that these cross-border referrals are happening anyway, and you have to kind of somehow cater for the migrants when crossing the borders. So it's better to use a systematic approach and to agree on some kind of a standard operating procedure. That's better than what is happening now. And also, the other side can access and download and feedback on these TB09 things, and the two parties can organize that. And what we are doing with these different scripts and languages, that's actually also the same for different standards. And because one thing is that the users cannot really understand on the other side, so the solution to that is just to print out the forms in both languages and English. And also we can print out in the standard TB09 format they like, if we set it up like that. That's the one way to also address the not really the shared standards. So as I mentioned, and tied to Thailand, to Myanmar, we have this possibility of paper mix, and that's quite useful to print out in the two languages and English when referring to Myanmar. Piloting Vietnam and Cambodia. It's you.
So this one I will continue with Professor Jones about the TB migrants currently in the pilots in the border of Vietnam and Cambodia. So we are doing pilots for the three provinces of Srai Vin, Ta Keo, and An Giang and Tây Ninh. So this is the map is in the south of the Vietnam. So this one in this project this one a list of hospitals involving for the An Giang province. We have 17 hospitals and Tây Ninh 14 hospitals. In Cambodia, So we are also have for the CNAS and target province for 8 hospital and screening for 10 hospital and also all the TB units. So what we have achieved until now, that we have already conduct a lot of meeting and the training for 2 countries, that's Vietnam and Cambodia. That we also include the bilateral meeting and the training. And we develop the application which on the picture needed for the referral include and the translation on the metadata, because as you see from the beginning, that's the language and the script of 5 countries is different. So this one is Vietnamese and Cambodia. So in order to understand and using the system, we only provide on the translation and also this the video of the how to use the system with the subtitle in Vietnamese and Khmer. So this one is the challenge. Challenge is, of course, from the Vietnam and Cambodia. When the patient come to do the treatment in Vietnam and then go back, they always have the problem because they will from Cambodia to Vietnam, they will bring back with the patient profile the treatment in Vietnamese, and from Cambodia to Vietnam is Khmer, so the doctor cannot use it. So this one we only solve the problem for them. But we have the challenge that at John only said that less data for the file loss province and the internet, of course, in Vietnam is better. We have some problem with the internet in Cambodia, and the workflow also different. So this one is the application that we only develop. We call it using it the eye capture developed by HIP Vietnam with all the picture, especially that is the searching by the keyword. For example, if you using the tracker capture, you can also only searching with the first name for different field, but this case we only apply the keywords. So you just enter any keyword to do the search. And then for the patient, so we allow them to do the patient profile, patient with the TB09 form in multiple languages. If they want to bring Vietnamese, Khmer, they just click and select the language to bring. And then the picture that we are working on is about the message sent to the user. For Cambodia, that we try to use the Telegram. But for other countries like Laos and Vietnam, we are using different. Vietnam, we are trying to use to send to Yalo and Laos for the WhatsApp. And other picture that we are. So this one is some of the screen. You can see this one for the register new patient. This one, if they are logging with the account in Khmer language for Cambodia, they will see the form on works in Khmer. And this one is the account with the Vietnamese version. They will see it in Vietnamese. Even this, we only have one metadata, one program, and one data element set. And then after they register the new patient, they can need to enter all the like the baseline with the information like the sign up, they see the treatment history and all other information, and then they enter the treatment. This one is not, we just collect some information enough for the transfer based on the TB09. We are not collect on the information like the TB case surveillance. This one is just focusing on the transfer only. So after that, if they want to transfer the patient out of the country, they just click on the stage called transfer out and enter the information, and then click on the transfer out. That's on. After that, they will in the site, or the site will receive the notification by message or email, and then they will accept that patient or not by enter the acceptance stage. So to bring out, so like this one is just the TB09, so they just 3 steps, select the patient from the list, they can do the select the patient in the list. This one is to bring the TB09 and then select the language. Like now we are supporting English, Vietnamese, and Khmer. Later we can set box for more like Lao and Thai. This one they from the same form they can bring in Khmer or in Vietnamese. So this is what we have done for the application on the form and the reports based on the TB09 form. So this is all about the TB migrants with the, so you have any question? And I will return this one to Nick.
Okay, thank you, Em. So I know it's getting a little late, of course. If you do have any questions for either presenters, Jason or Emma and Jorn, if you're kind of tired, I understand you can leave, but for those who want to stay, please do so.
Yeah, just a quick question to the previous presentation about the exchange app. Just out of the curiosity, for example, if I have two DHIS2 accounts, one that I am the super user, and another one is that I am the user only. I just wonder, to transfer the data from the user account to another DHIS2 instance that I am the super user, is it possible, or do I need to have the permission from the super user of the first DHIS2 account?
Yeah, so I didn't go into detail about this. On the server that you're transferring data to, you need to have the right permissions to transfer data. And what those permissions are, you need to be able to import data. You need to have access to the data set that you're transferring data for. And you need to have the permission to import data. I think I already said that maybe. Yeah. But you absolutely don't need to be a super user, right? And it's definitely not recommended. And the reason for that is that, you know, on your local instance, those credentials are stored. The username, the password is encrypted, so it's you can't get to it basically, but still not ideal. That's why we recommend the use of a token instead of a username and password, right? But yeah, on the remote system, you absolutely don't need to be a super user. You just need to have the correct permissions to import the data, basically. On your local instance, and I didn't go into this in detail, but you can also decide who has access to perform the data exchange. So in the case of, say, you know, you might be transferring data, the TB program officer might be transferring data to the global TB program. But that specific user should have the authority to do that, but like nobody else. Like he holds the ultimate authority, essentially. So you can configure the exchange to say that many users can view the exchange, but only one particular user can actually transfer the data to the remote server. And again, that user doesn't need to be a super user on your instance. They just need to have enough permission to be able to see the data exchange app. But there's no reason why you have to have a super user involved. But you know, it does require the correct configuration. I hope that helped to explain. Thank you.
Yeah, thank you so much for introducing these great features into the DHIS2. I think it will help a lot. So I have a couple of very short questions. So the first one is that the data can be transferred from data element indicator or program indicator. So in the destination, it will be transferred to the data element.
Correct.
So my question is whether we can use the same data element in the destination in the data set. And another, I've seen that you have configured a lot of data transfer. So whether we are transfer manually or it can be scheduled, and also the app, which version of DHIS2 can support this app?
Yeah,
Thank you.
Thanks. I'll try to remember all of those. So you need at least version 239 for this to work. It should work in all versions after 239, as far as I know. Oh yeah, can it be the same data element? Yeah, it could be, absolutely, right? Yeah, I mean, a good example of this might be if you're using a standardized metadata package from WHO, right? This is a theoretical example, but let's say that you're using one of the metadata packages from WHO on whatever, TB, and you're transferring data to the global TB program. They might also be using that exact same data element, right, with the same UID. So yeah, you could. It could absolutely work that way. You had one more question as well.
It was about the transfer. Can we schedule the transfer so it happens automatically?
Yeah, I mentioned that it can either be done through the app, it can also be scheduled regularly, or you could also trigger it via the API. You might have some complicated job that you need to script, basically. So yeah, those are kind of the three ways that you could do it. Yeah.
Any other questions for Jason or Jorn and M on the TB migrants?
Yeah, in theory you could, right? But that external system would need to understand the DHIS2 payload, right? So yeah, you could do it, right? But that external system would need to know how to interpret what you're sending it. But yeah, I mean, you could think about a theoretical situation where you have some external web service that can consume a DHIS2 JSON file that's well described and documented. Yeah, I don't see why it couldn't happen, right? It doesn't have to be DHIS2, but that external system would need to know how to interpret what the server is sending it, basically. Yeah, it could be, right? I mean, I don't see any reason why it couldn't happen, but you would have to write some web service on that side to say, okay, you know, this is a DHIS2 data payload, and I need to know how to decode that. But it's just JSON, right? It's just standard format. It's well documented. So, yeah, I mean, it could be done in theory, I think.
Okay, so I think that will wrap up the session for today since we're a little over time as it is. So yeah, thank you everyone for your patience. I know we're a little over time today, but we'll wrap up for today. We'll start again tomorrow. There's no parallel sessions tomorrow, so we'll all be in this big room. So we'll start up again at 9 o'clock in the morning. And yeah, everyone have a good evening, and we'll see you tomorrow. Okay, thank you.